இல்ல வணக்கம்.
வணக்கம்.
வருதுங்களா? எந்த
வரல.
Jalil sir, good afternoon.
Good afternoon. Good afternoon all.
வருதா?
வருது.
முருகமலை நேம் பேராணி முருகமலை.
ஸ்லைட் ஷோ போட்டு பாத்துருங்க.
Senthil sir, good afternoon.
சார் வணக்கம் சார்.
Jalil sir, good afternoon.
ரமேஷ் பாபு.
Murugan.
Hi Mona.
Captain sir.
Hi. Your speaker is muted.
Yeah. I'm also trying to share screen, but நடக்க மாட்டேங்குதுங்க.
Good afternoon.
Yes sir, good afternoon. Jalil sir, good afternoon.
இஸ்மாயில் அண்ணா வணக்கம்.
வணக்கம்.
டைப் பண்ணனுமா இங்க கீழ பண்ணனுமா? டைப் நேம் அப்படி இல்ல ஹாய்னு சொல்றதுக்கா? அதுல ஒரு ஆப்ஷன் வரும் சாட்ன்னு.
ஆரம்பிச்சலாமா?
Should I also share my slides?
Yes ma'am. Can try.
அங்க விடுங்க.
Sorry, Dr. Newton, can you tell me the name of his screen name, your screen name, so that I can make you a co-host?
Sorry? Should I send as an email to you?
Yes, ma'am.
Yes, Dr. Mona.
Should I send as an email to you? I'm not able to browse my.
Yeah, you could do that.
Can I try?
Can you
Can
you tell me your email?
No, I'll just post it. I'll just post it in the chat box, sir.
Okay.
Can I just try?
திருமுருகன்
சொல்லுங்க சார்.
ஸ்டார்ட் பண்ணிடலாமா? நம்ம வந்து இப்போ டைம் ஆச்சுல.
We are already few minutes late, 5 minutes late.
Yeah, we'll start. Okay. Good afternoon to everybody. And we'll start with pediatrician prayer. Pediatrician prayer, Dr. Gopal Subramaniam, Treasurer IAP TNSC will deliver.
அனைவருக்கும் மதிய வணக்கம். குழந்தை மருத்துவனின் இறைஞ்சூதர், எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழ்நிலைகளிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். வணக்கம்.
Thank you, Dr. Gopal. On behalf of IAP TNSC, I welcome our Vice President of South Zone, Dr. Major Nagaraj sir. Welcome, sir. I welcome our President 2021, Dr. Ismail sir. I welcome Dr. Ismail. And I welcome our past President 2020, Dr. Adolescent sir. I welcome Dr. Ramesh Babu, President-elect 2021. I welcome Dr. Ramesh Babu.
Thank you.
Gopal Subramaniam, Treasurer IAP TNSC. And again, I am on behalf of IAP TNSC. I welcome adolescent experts, Dr. Swadi Bave, Dr. Priti, Dr. Newton Lewis, Dr. Mona Bhaskar, and today's the star-studded speakers like Dr. Vijayarani, Dr. Usai Lango, Dr. Agila Iyavu, Dr. Aram Sendil, Dr. Lasmi Santi, Dr. Sri Priya, and I welcome our Vice President IAP TNSC, Dr. on behalf of IAP TNSC, I welcome one and all for this wonderful adolescent pediatric CME. This is the first CME we are having this year. We start with adolescent pediatric. I welcome one and all. Now I welcome our President, Dr. Ismail Ji, to deliver presidential address.
Good afternoon, everybody. Vice President of the Central IAP, Major Nagaraju sir, Past President and my friend Dr. Sendal, President-elect Dr. Ramesh Babu, Secretary Rajendran, and my friend Treasurer Gopal Subramaniam, and all the experts who are going to speak today, and the speakers, my respected teachers. As the President, I welcome you all, and I wish you all a very happy New Year and a season's greetings. I'm happy that this year we are starting with a program which is close to my heart. I think it's mandatory and it is our duty as pediatricians to play a vital role and help the parents in the community to groom the children in a matured way. Yeah, we need to help them, especially in the transition period of becoming into an adult. We need to play definitely a very reasonable role. Famous psychologist Erickson said, the more you know about yourself, the more patience you have for what you see in others. This is the stage where a child undergoes a range of emotions: boundless joy, anger, frustration, hatred, depression. As you all know, it is like handling an adolescent is like performing a Bharatanatyam in a revolving platform. As we pediatricians usually are very good counselors and we have utmost patience, we need our skill and we need to play a pivotal role in shaping up the adolescents. This year, as the President, I assure you, we are going to talk to the parents. IAP is going to take definitely a step to talk to the parents, to motivate them, to bring in awareness as far as the adolescent care is concerned. We are working out a plan and we wanted every adolescent in Tamil Nadu to bloom into a very good citizen with a good character and in a matured way. Hope today's program, I think it's going to feed you new vistas and it may be some eye openers as well. The faculty are all well trained and they are all stalwarts and experts. I request all of you to utilize this good opportunity and learn something useful and practice for the benefit of the adolescents of our state. With these few words, I welcome you all once again to the CME and I thank all for accepting this opportunity to participate in the CME. Thank you.
Thank you, Dr. Ismail sir, for your vision and plan about adolescent pediatric this year. Thank you, sir. Next, I welcome Dr. Ramesh Babu, President-elect.
Rajendran sir, your volume is very low.
My audio.
Ama sir, audio romba kammiya
Is it
irukku
okay?
Okay now. Okay.
Okay.
Thank you, sir.
Now I welcome Dr. Ramesh Babu, President-elect 2021, to give few words regarding Felicitation.
Thank you, Dr. Rajendran sir. Good evening all. Good evening, President Ismail sir, Past President Adolescent sir, Vice President of our IAP, Dr. Major Nagaraju sir. I thank you everyone for giving me this opportunity. I wish to state that IAP Dharmaburi branch have enrolled 10 members in adolescent health group over the past 2 months. Vijay Rani madam told that 15 members is enough to start a district branch chapter for an adolescent group.
Separate chapter.
Yeah. Yes. I think only Chennai is having the adolescent chapter in Tamil Nadu, district chapter. Even Vellore, I think they haven't started it. I wish our district should have few more adolescent district chapters. And they have won the adolescent chapter has won the Central IAP award for the best subspecialty award in the All India Central IAP Awards awarded last year. I think we should still work hard and bring more laurels to our state adolescent health group academy also. I wish it would happen under the tenure of our present president, Dr. Ismail sir. I won't take much time. We can go to the proceedings of the CME. Thank you for giving me this opportunity. Thank you, sir.
Thank you, Dr. Ramesh Babu. And this next time for the inaugural of our CME. Now I welcome Dr. Majan Nagaraju, Vice President, South Zone. Sir, please take over.
I think it is a great pleasure to be here. Good afternoon to all of you. And my friend, Muhammad Ismail, the President of IAP TNSC, and Dr. Sendil, past President of IAP TNSC, and the Program Coordinator, the Secretary of the IAP TNSC, Dr. Rajendran, and the Treasurer, Dr. Gopal Srinivasan, the Vice President of IAP TNSC, Ilam Murugan, and the CIAP EB member, Dr. Jalil, and other members who are present here, and also dignitaries and faculties and other friends who are here attending for this wonderful program conducted by IAP TNSC. First of all, I must thank the IAP members of Tamil Nadu to elect me to this coveted post. Thank you all of you for giving me this opportunity to all of them. First of all, I must thank all of you for this thing. And I also must thank IAP TNSC under the leadership of IAP, under the leadership of Dr. Sendil, who bought so many medals for the IAP. So many laurels also has come from the Central IAP. It is really worth to talk about that thing, and all must give a big hand to this Dr. Sendil for giving us IAP TNSC such a so many awards. And you know that today's program CME is a very important one, and we have got adolescent specialists are around, Dr. Swati Bhave, Dr. Preeti, and Dr. Vijay Rani. Vijay Rani might be remembering me. We are the first batch of adolescent batch. Though I was not interested about adolescents, Dr. M.K. Sinha pulled me and made me a first person to pass out from along with Vijay Rani and Yamuna and other people. We have completed the course at that time, first batch. And we are the first people to start IAP Adolescent chapter in Tamil Nadu, along with the Sunil Srinivasan, myself, and Dr. Virdugari, were the people who have started. And afterwards, I took over as secretary. Then once I became a secretary of IAP Tamil Nadu State, I left that adolescent field, and it is not my cup of tea, I thought, because we are more concentrating allergy and immunology. That is the reason. Today, we have got a very good topics, and it will be very useful for most of the practitioners. Everybody practice this today's talk, and it will be very useful for our adolescents, what Dr. Ismail has told. I'm happy to inaugurate, and I inaugurated this thing, and thank you for this opportunity given to me. Jai Hind, Jai IAP. Thank you.
Thank you, Dr. Majan Nagaraj sir. I think your tenure will get a lot of central program for Tamil Nadu also. Thank you, sir. Next, I welcome our coordinator, Adolescent Pediatric coordinator, today's program also, Dr. Aram Sendil sir, to deliver talks. Dr. Aram sir.
அகரமுதல எழுத்தெல்லாம் ஆதி பகவன் முதற்றே உலகு. அனைவருக்கும் இனிய மாலை வணக்கம். The dignitaries of today's program. Am I audible?
Audible, sir. Audible.
The dignitaries of today's CME of IAP TNSC, Vice President Dr. Major Nagaraju, the President of IAP TNSC 2021, my friend Dr. Ismail, the President-elect Dr. Ramesh, and the office bearers Dr. Rajendran and Dr. Gopal Subramaniam. Today's adolescent CME with excellent experts in the field of adolescent medicine. I welcome Dr. Swati Bave, Madam, Dr. Mona Bhaskar, Dr. Preeti Galagali, Dr. Newton Lewis. So, I mean, they are coming from all over the southern part of India, and they are so much passionate about this adolescent pediatrics, and we have called them for as the experts in today's CME. And of course, our speakers today, Dr. Sri Priya, Dr. Vijayarani, Dr.
Akila,
Dr. Akila,
Mona Bhaskar,
and
Mona Bhaskar.
Yeah, she'll be the expert. So all are going to deliver, because this CME was actually conceived to be in 2020, and because of the way so many programs and we had so many commitments, it actually came over to 2021. And I'm happy that Dr. Ismail, who is so passionate about adolescent pediatrics, is going to have this as a first CME. And so I wish him all the best for his tenure. So let him have a fine run, and let him get many more laurels to IAP TNSC. So with this, best wishes. And of course, I welcome all the delegates and the central EB members and all our state EB members, or all the office bearers of IAP TNSC. And with this, we would like to go to the CME proper. So today's first speaker, I think before that, Dr. Vijayarani, the South Zone Coordinator last year, she will be telling a few words, and then we'll go over to the CME. Over to Dr. Vijayarani. Dr. Vijayarani, you have to unmute.
Warm welcome to all the office bearers and the new president, Dr. Ismail, and a very warm welcome and pranams to Dr. Swati Bave ma'am, and the speakers from other states, Dr. Preeti Galagali, Dr. Newton Lewis, and our own professor, Dr. Mona Bhaskar. I welcome you all, and I'm very glad that we have done a great job last year under the leadership of Dr. Sendil, and looking forward to work more under the leadership of Dr. Ismail. Thank you, and we would continue with the program, waiting to hear from all the star speakers. Thank you.
So today's speaker first will be the opening batswoman will be Dr. Sri Priya. She's a adolescent physician from Vellore, a passionate speaker. She was the secretary of the IAP North Arcot branch 2019. I think 18 also she was there. So she's in government services also, and she's so passionate about adolescent pediatrics. She'll be talking about body image concerns, and the expert of this session will be Dr. Mona Bhaskar. She is the professor of pediatrics in CMC Vellore, and she's has so much rich experience in adolescent pediatrics and adolescent counseling. So she's been doing a pioneering work in CMC, and she's been doing a job so silently and so meticulously. And she's a wonderful speaker, and she'll be the expert of today's session. And with this, we'll go to the session, Body Image Concerns by Dr. Sri Priya, and the expert will be Dr. Mona Bhaskar. Over to Dr. Sri Priya.
Thank you, sir, for the nice introduction. Vanakkam, everyone. And thanks to our state IAP for the good opportunity. Body image issues. Let us have a look at these scenarios. 15-year-old Dhruv feels that his jawline is not as chiseled as Ritik. He may also feel, why am I not taller? My shoulders are not as broad as I want them. I wish I was more muscular. 14-year-old Kesha says, I hate to see myself in the mirror. Pimples on my face make me look ugly. And oh, my hair, it should have been straight. I wish I had bigger breasts and a slimmer waist. I envy my friend Shreya, who has a perfect figure. This could be my story or your story in flashback. What is body image? Body image is what you perceive, think, and feel about your body. It has 4 aspects. What you see is perceptional, what you think is cognitive, what you feel is emotional, and the other is the behavioral aspect. And it does not necessarily reflect what you see in the mirror or what other people see. Let us have a look at the short statistics. 50% of 13-year-old girls were unhappy with their body. This number increased to nearly 80% by 17 years of age. And nearly 80% were afraid of becoming fat. Project EAT reported 19% of high school girls were on chronic dieting and 57% were on unhealthy weight control behaviors. The male adolescents were more concerned about their muscularity and leanness, while the girls were concerned about the thinness. 25% of the male adolescents were concerned, and around 17% were dissatisfied with their bodies. With this background, what is body positivity? Feeling comfortable and confident with your body, accepting its shape and size. This is not to encourage obesity, but to say that you need to love your body no matter where it is on the appearance spectrum. That is, love your body with all its imperfections. What are the protective factors for a positive and healthy body image? Let me start with healthy self-esteem. Body image is much more influenced by a healthy self-esteem than just physical attractiveness as judged by others. Self-esteem, as said by, as usually Swati madam used to say, the importance of imparting life skills. So imparting a good, healthy self-esteem as well as developing critical thinking goes a long way in their lives. Self-esteem is a universal vaccine which is going to protect our youngsters from body image crisis. Then, positive feelings about physical changes in puberty as well as getting the right factual information about the changes in puberty helps them a lot. And of course, we all know the importance of healthy eating and exercise. Body image is not inborn, it is learned. And from where do they learn about their own body image? These 3 big factors: media, parents and relatives, and peers. Internalization of messages starts from a very young age. By 2 years, the child starts to recognize itself. And by 4 years, they start to compare themselves with others, and it is mostly about clothing and hair. And by 5 years, the wish is to become bigger. 6 years is the age where socio-cultural factors start playing. Now, let us see the various factors that influence body image as far as media is concerned. The first comes the internet, which is followed by the TV, and then the articles in the newspaper and magazines. Media. When the adolescents flip through the magazines or watch TV, they come across perfectly photoshopped models and celebrities. But after putting the magazine down or switching off the TV, They walk away, of course, with some impact, but scrolling on and off through Instagram, Facebook, etc., and seeing their friends in an edited to perfection form, more than seeing a celebrity or stranger with whom they don't have any connection with. This has more effect on their self-esteem and general happiness. How does this affect our young boys and girls who have exposure to such media 24/7 right at their fingertips? 30 minutes of social media a day can negatively change the way teens view their own body. And advertisements. Insecure teens are motivated customers. They purchase solutions for their body image issues, regardless of whether it works or not. Articles in various websites and magazines. Girls who read these articles on dieting and weight loss are 6 times more likely to present unhealthy weight control behaviors, and boys 4 times likely. What is the role of the parents? Parents' opinion and behavior of parents and adults determine the way the child feels. Are we helping the kids to better understand how their bodies change during puberty? Are we really listening to what kids say and discourage any negative talk about their appearance? Are we reassuring our children that we accept them as they are and give them unconditional love? Are we careful in how we suggest changes in their dressing, hairstyle, etc., allowing them to feel comfortable in their favorite clothing, trying new haircuts, new hairstyles, etc.? Are we enabling them to experience the physical strength of their bodies and positive feeling of movements, regardless of their size and shape? And are we showing them that eating fruits and veggies are enjoyable, or are we just insisting it as a part of dieting just because they are healthy? Are we remaining close and supportive to children as they experiment and struggle with body image and grooming? Peers, just as parents, play a vital role in developing body image. Messages and comments from friends are perceived as more meaningful and credible than from anybody else. Their body image is determined by ideal body images they are exposed on a daily basis. For example, in a community where a long neck is a symbol of beauty, teens with shorter neck will feel bad about their body, even though there is nothing inherently wrong with them. So their ideal body image is from what they are exposed to. Promoting a body image to a friend by appreciating their body functionality leads to improvement in one's own body image. People easily make fun on the appearance of others. Some even think shaming is a potent way of motivating them to transform themselves, and even they think it will make them work harder to achieve this miracle. But it only makes them more insecure. The feeling of not measuring up to others' perception keeps lingering for decades in their lives. Body dissatisfaction is so common that it is called as a normative discontent. Body satisfaction hits a low between 12 to 15 years, that is early adolescence, the later part of early adolescence and middle adolescence, because there are so many things happening at this age together, like puberty, social changes, peer influences, etc. Studies generally found a greater body dissatisfaction in females than in male. Generally, in females, it is from 30 to 80%, and males 20 to 50%. And in our study in our state, held by Subhashini et al. At Coimbatore, 77.6% of adolescent girls express body dissatisfaction. Body dissatisfaction is also largely overlooked in boys. A muscular V-shaped structure with a broad shoulder and a thin waist is portrayed as the ideal body form for men by media. But feeling of embarrassment makes them feel demasculinized, these young adolescent boys. This leads them to high-risk behavior like alcohol, drug addiction, anabolic steroid use, and drives them towards depression. This is one version of a 19-item self-administered body image questionnaire. It has got a few favorable items, and the score for each item is from 1 to 5, like healthy, being expressing, daring, etc. And there are also few unfavorable items where we have to use reverse scoring from 5 to 1, and like physically unattractive, being impure and dirty, etc. And for the item 4, for boys, masculine will be score 5, and for girls, feminine will be score 5. And at the end, add all the 19 answers. The total score may vary from 19 to 95. A high score corresponds to body satisfaction. These are 10 steps to a positive body image. Appreciate all your body can do, your movements, your activities, and keep a top 10 list of what you like about yourself. Look at yourself as a whole person. Choose not to focus on specific body parts. Surround yourself with positive people. Shut down any negative voices in your head, which tells that your body is not right or that you are bad. You can overpower your negative thoughts with positive thoughts, and wear comfortable clothing which makes you feel good about your body. Always work along with your body and not against it. Always be a critical viewer of social and media messages. Do something nice for yourself, something that lets your body to know that you appreciate it. Use all the time and energy you spend in worrying in helping others. Sometimes reaching out to others can make you feel better and can make a positive change in your world. These are the effects of poor body image: unhealthy dieting, over-exercising, eating disorders like anorexia nervosa, bulimia nervosa, binge eating, avoidant restrictive food intake disorder, and other disorders, body dysmorphic disorder, muscle dysmorphia, low self-esteem, depression, and anxiety. Thank you. And Mona ma'am will take on discussion from now.
I sent it to Dr. Thiru.
Dr. Thiru is having the slides.
Can you hear me?
Dr. Thiru's now it is.
Yeah, I sent it to him.
Yeah, he's sharing.
While he's doing, I just want to thank all the organizers for giving me this opportunity to speak here about body image. Dr. Sripriya has kind of said most of what is related to body image. I'm just going to add on a little bit of studies and other articles where we learn about body image concerns for adolescents. How do I change the slides? This is the first slide. Can I operate the slides or?
You're able to view the slides?
Yeah. This is not the first slide. That's okay. Let me start with this. No. Again, that's not the first slide.
Your voice is not clear, madam.
Can you hear me now?
Yeah. But when you go for the slides, I think it is not clear.
Can you hear me? Can I start from the first slide?
Go ahead, madam. Go ahead.
All right. So, like Dr. Sripriya said, body image is a picture that a person sees of their own body, irrespective of how it looks, how it actually looks. And then this is something that we need to understand to see what exactly an adolescent teenager goes through with regard to body image dissatisfaction. Body image is complex. It involves thoughts, feeling, evaluation, and behaviors. and it is one of the components of adolescent identity. And there are several researchers in the past who talked about a biopsychosocial approach to body image, and that it is a dynamic thing which changes with age and even change of clothes. Right? Or okay, it's a multi-dimensional concept that Dr. Sripriya talked about. But when you think of perception, it basically starts with all the various data that you think of regarding from the sensory organs and interprets in the brain and be interpreted in the brain. And then because of that, we have a particular perception of our body. Sure, it can be healthy or it can be unhealthy. Right? What is a negative body image? Basically, a discrepancy between what we perceive in our body, what is considered as an ideal image. And so that's the reason all the outside social culture influences may cause the negative body image. It includes dissatisfaction with the body, preoccupation with
Madam, can you switch off your video and talk, madam?
It also involves behaviors with regard to a negative body image. And negative body image is measured as body dissatisfaction, body image dissatisfaction. Right? What's positive body image? Basically, it has multiple components where a person can appreciate the body and how the body interacts with the world. It has to be self-compassion, so that you cannot be all the time feeling guilty or disgusted or bad about the body. So it's the opposite of that. And also understanding that nobody's body is perfect, and health should be considered as a whole body health and not just the appearance, and not just as weight loss. Essentials for a positive body image are increased physical activity, a balanced diet, sleep hygiene, healthier sexual habits, and overall general habits. So development of body image, as you can see from this slide, starts off in the life when there is a feedback between the motor system in the developing fetus and the sensory input from the surrounding fact that the baby is in. Prenatal and postnatal experiences teach you about your body image. And self-recognition, like Dr. Sripriya had said, starts at around 2 years. And by about 6 years, it becomes a bigger problem of body image and dissatisfaction. And one study showed that among 6 to 12-year-old children, school children, 40 to 50% talked about dissatisfaction with some part of the body. Next slide. So there is development within the adolescent age. Body image, as you know, is critical, and it happens in a critical stage in the adolescence. Because adolescence per se is a transition at a dynamic stage in life, body image kind of problems related to body image happen a lot more among adolescents. It's influenced by specifically positive and critical messages from parents. And there is enough evidence in this literature to say that parent-teen interaction has a significant impact of and cause body image dissatisfaction. As they grow into middle adolescence, parental information or parental reactions are less important and peer response is more important. And what is known is that if there is a critical event or a series of events, it does result in body image dissatisfaction or a negative body. Right? So in early adolescence, there is a lot of uncertainty about whether my body is growing normally or not. Is it the same as my friends? Things like that. And an early adolescent requires a lot of reassurance from family and the healthcare provider. In middle adolescence, there is a preoccupation which shifts to, am I attractive to the same sex, opposite sex, whatever they are interested in. Late adolescence shows a lot of balance with introspection and then less emphasis on external characteristics, by which time they are stabilized about their appearance and image. Next slide. So this is just a list of all the factors that can affect body image and therefore body image dissatisfaction or a negative body image. So age, gender, pubertal changes, culture, society, self-esteem within themselves, any kind of chronic illness, whether psychiatric or physical illness, sexual abuse, physical abuse. And next slide, please. Now, what is dysmorphia? Dysmorphia, by definition, is a condition where a person falsely believes that there is something wrong with their size or shape. So there may be no defect in the body, or there may be a very mild defect in the body. But the person feels that that is a huge, big problem. That is dysmorphia or negative body image or a body image dissatisfaction. And prevalence, like Dr. Sripriya said, is quite high, higher in girls and in boys. Girls aspire to be thinner, boys tend to look for an athletic body shape, and there are definite ethnic differences. Dissatisfaction is less among African American women compared to white women. This is what some studies have said. Next slide. Okay, so you look at this from dysmorphia per se, what is normative? Most people, when they're looking at media and an ideal from the media, may have some amount of dissatisfaction with the body, which falls under the normative. It goes on into pathological when it becomes more severe. Next slide. Pathological could be transient or chronic. Next slide. And in the thought process, in pathological, it may be just one idea, which is an abnormal idea. There may be a problem with the body which is not significant, but it may just be an idea. And it moves on to more severity as being an overvalued idea. And then finally, a delusion, which is a very significant psychiatric symptom. Next slide. If you look at disorders, among organic disorders like temporal lobe epilepsy comes under the pathological state. And there are several psychiatric illnesses where there is body image dissatisfaction. Next slide. Here you can see even under psychiatric, under organic temporal lobe epilepsy, under psychiatric, there may be any kind of psychosis or mood related disorders, and specific psychiatric disorders, which is body dysmorphic disorder, very significant severe illness, and eating disorders also common. Right? So when you look at differential diagnosis, I'm going to list out 14 different diagnoses for body image dissatisfaction, starting with what is normal, going on into a continuum to unhealthy body perception. Normal appearance, many people seem to have normal appearance concern. Many people seem to have it is increasingly common. There is more interest in cosmetic specialists, procedures, etc. What is dysmorphic concern? When there is excessive concern about a particular body part or body, and there is preoccupation with that, whether it is a body part or a preoccupation with the body odor or function, etc. But this is not necessarily a psychiatric or a DSM diagnosis. Next comes disordered eating. Again, this is not like a definite DSM diagnosis, but there is abnormal thoughts, beliefs, behaviors along towards food, and there is some amount of negative body image. And unhealthy weight control beliefs and practice do happen. This is a risk factor for developing an eating disorder. So if you catch a teenager with these kind of symptoms, it's important to address it and not say that, okay, they are just trying to be and things like that. Right? Anorexia nervosa is another differential diagnosis for body image dissatisfaction, very typically. It's one of the most severe manifestations of body image dissatisfaction. Prevalence is 0.4%. Body image dissatisfaction is a core characteristic. Distortion occurs in attitudinal levels and in perception. And you know the DSM criteria. Amenorrhea is not anymore. Right? Bulimia nervosa, again, debilitating and potentially life-threatening disorder, recurrent episodes of binging. Typically, what is binging? When there is excessive food intake with a sense of lack of control over what you do, followed by inappropriate compensatory behaviors, anything, vomiting, exercise, laxative abuse, all of it. Self-evaluation and self-worth unduly influence the body weight. And bulimia nervosa usually have a chronic or intermittent course. And it may often persist for several years. Next slide. Muscle dysmorphia is something new. It is a rare variant of body dysmorphic disorder focused on muscularity and mostly in men. There is an extreme desire to gain lean muscle mass and preoccupation with the perceived lack of muscularity. So it is kind of a reverse form of anorexia nervosa. A new term, vigorexia, has been coined. It means a mental illness where a man worries that his body is too weak and too small. And there is significant social, occupational impairment, psychosocial problems, embarrassment over perceived flaws, and then because of which there may be high risk behavior using androgenic steroids, excessive workout, and things like that. And the tendency for social withdrawal. Right? Binge eating disorder, again, it's a DSM diagnosis, recurrent episodes, large quantities of food, binge eating without any control over it, and without any purging behaviors. Next slide. Body dysmorphic disorder basically is a severe form of illness where we have seen teenagers who are very preoccupied with one or two defects in the physical appearance associated with repetitive compulsive behaviors like mirror checking, excessive grooming, camouflaging, always comparing features of their own features with other people mentally, all the time thinking about it. And because of this, they will have even delusions of reference. That is basically they keep having these thoughts. They're just thinking thoughts which preoccupy their mind that somebody else is mocking them or making fun of them. And like in anorexia and bulimia nervosa, body image dissatisfaction precedes the onset of disease in body dysmorphia disorder. And it's got very high rates of depression and suicidality. In the general population, it's about 0.7% prevalent. Adolescent population is a little higher, about 5%. Next slide. So there are other disorders dissatisfaction. So body image dissatisfaction or BID is a prominent feature in all these. OCD, social anxiety, major depression, general anxiety, deliberate self-harm, which is like cutting, and trichotillomania. Okay. So there are several psychometric tools for evaluating body image dissatisfaction or body image within an illness or even in a normative population, which includes like attitudinal tools, perception tools. Attitudinal tools, basically the teen will respond to a questionnaire where they talk about their feelings about your body, size and shape. And in perceptual kind of tools, they look at accuracy, how they judge dimensions of their body or body part. Another tool is eating disorder inventory. It looks at body dissatisfaction subscale, drive for thinness subscale, and interoceptive awareness subscale. And a whole bunch of questions within these three subscales. Next slide. Treating body image dissatisfaction, cognitive behavioral therapy is the most commonly used, best proven intervention in various disorders. Next slide.
Madam, 2 more minutes, madam.
I think I'm not going to finish because there's lots more to talk. If you want, I'll stop. Just tell me when to stop.
Okay,
Other
ma'am.
things
Thank you.
include fitness, media literacy, media resistance, cognitive remediation therapy. Next slide. Pharmacotherapy. Next slide. It's specific for each of these disorders. Next slide. Next slide, please. So there are a lot of medical complications as listed here, especially for anorexia nervosa, involving most of the systems. There are a lot of mental health complications. Next slide. Prognosis, depending on what disease it is, there is poor prognosis or moderate prognosis. Next slide. It is treatment is very challenging in body dysmorphic disorder, and they need medication for a long period of time. Pharmacotherapy with CBT has proven efficacy, and suicide mortality rate related to body dysmorphic disorder is pretty high. Next slide. So there are some interventions I just want to focus on this to promote positive body image. Parental education about the importance of a positive image during annual check is important. Assess for body image concerns during a clinic visit. First and foremost, check our own biases as a clinician regarding body shape and size. Do we have body image? Specifically for athletes, counsel them regarding adequate nutrition, supplement use, and unsafe patient behavior. It is not useful to keep a teen patient category saying overweight or obesity. Instead, shift focus from weight and BMI to overall health. Basically, celebrate all sizes and say whether you're fat or thin doesn't matter as long as you're exercising and having a balanced nutrition throughout. Also, never assume that a normal weight teen is not using unhealthy practices. Next slide. Next slide, please. It's important to avoid potentially harmful language while dealing with adolescents. To start with, never categorize them that you're in the obese category for BMI. Like that. Never compare them and look at them along the curves. Don't be judgmental in the way when you talk to them. All these are, you have to be mindful of it. Next slide. Next slide, please. Use patient-centered language. Health is so much more important than a number on screen. What do you about your health? Be body positive. Say something that you appreciate about your body. Use positive body image overall language while dealing with an adolescent. Studies have shown that school-based education or parent education programs are not that effective in preventing body image dissatisfaction among us teenagers. What we need to know as adults, parent, teenager, healthcare professionals, we should be aware of body image dissatisfaction related disorders, in particular anorexia, bulimia, binge eating disorder, and see early intervention. It is a very complex illness if you take just anorexia, bulimia, binge eating in a clinical scenario. An interprofessional team is very, very important for achieving optimal outcome.
Thank you for the wonderful question, Dr. Sri Priya and Dr. Mona Bhaskar. Ismail, you want to say?
Yeah, thank you. Thanks for the wonderful lecture. Dr. Sri Priya, just one question. I just wanted to ask you, as a practicing pediatrician, if a child is brought to by the mother with a problem of a body image, what you expect a pediatrician to say to the mother? Suppose, for example, your case scenario, Duru, is brought to my clinic with the similar complaints. What am I supposed to say as a carry-home message? I just want you to summarize in just 3 or 4 sentences. What can I deliver it to him?
I didn't hear you.
In such cases, the child will be preoccupied and keep on repeatedly checking itself and keeping on repeating about their negative attitude to the parents, mainly at home at least, or to the peers. So they have to keep, whenever they say such things, the parents have to keenly listen and then keep explaining about them to not such carry on such negative thoughts about their appearances. They should not encourage such negative thoughts.
Dr. Mona, can you add anything?
I think madam is not reachable.
Okay, Dr. Preeti. Dr. Preeti, madam, you're online.
Okay, I think we can have at the end of the sessions, we can go to the next Sendil. Dr. Vijayarani, you can introduce Dr. Sendil and other speaker.
The next topic is on risk-taking behaviors by Dr. Aram Sendil and Dr. Swati Bave ma'am. Dr. Aram Chandil is an adolescent pediatrician from Neyveli, and he had been working for this cause for many years, more than 15 years. And he was IAP president 2020. He needs no more introduction. And ma'am, of course, she's a mentor for so many pediatricians here. She also does not read any thing, but I would like to highlight a few things. At present, she's the executive director of AKI, Association for Adolescent and Child Care in India, which is an NGO working for the cause of adolescents. And also, presently, she's working on non-communicable disease awareness, and she's done a lot of program. And the NCD Child is a very nice project. We should look into that. It's all available in the net. Also, she is, after a very long time, she became the IAP, women IAP president in the year 2000. And where that was a period we all met her, and she did the next year, she did the international program, ITPA, where she brought a lot of international faculties and introduced us to many people, many teachers and professors. Another thing is she was visiting consultant to the Kalamazoo Michigan State University College, and also Harvard Medical University in Boston. And she has authored so many books, and markedly textbook, Bave's textbook on adolescence. And she's got many medals, many publications, etc., etc. And the time is not enough to introduce her. Over to Dr. Chandil.
Thank you, Dr. Vijayarani. Before to Sendil, I just wanted to, as a speaker, only one thing is, most of them are practicing pediatrician, expecting something from you. So I just want to conclude before you finish, just add on few points what the practicing pediatrician can say to the parents when such behavior is brought to his clinic. Thank you.
Yeah, am I audible?
Yes, Sendil.
My screen is visible?
Yes. Go ahead.
Okay. At the outset, let me thank Dr. Ismail and his office bearers for giving us this opportunity for this adolescent CME. I'm going to deal about the risk-taking behavior in adolescents. So what Dr. Ismail was telling about the practical aspects. So let us, I think at the end of the session, we'll deal some practical aspects also. Dr. Swati Madam will deal about the practical aspects. I'll be going into the details of this risk-taking behavior, which is really a gray area. And for this betterment of the adolescent of the future of India, this is really necessary, as that's what I felt. So according to World Health Organization, this is a phase which involves the progression from appearance of secondary sexual characteristics to sexual and reproductive maturity, and also the development of adult mental process and identity, including the transition from total socio-economic dependence to relative independence. So the transition zone between childhood and adulthood is adolescence. We know the stages of adolescence: early, middle, and late. The late adolescence spilling over to even 21 to 23 years. So the early adolescence is a stage for the involvement in different kinds of high-risk behaviors, since they are easily influenced during this vulnerable period. This is the period where they should be captured for health prevention. So what is the definition of risk-taking behavior? It is the behavior or activities that lead to mortality, morbidity, and social problems among adolescents. These actions that can affect one's physical, psychological, and emotional health. Such risky behavior usually results from lack of knowledge and understanding by the adolescents. This risky behavior or sensation seeking is when a decision to do an act is taken impulsively, without thinking, based only on feelings and desires. These acts have no planning, but are encouraged as fun and daring, and often mistaken by the adolescents as adventure. I will later differentiate between the two. So the risk-taking behavior in adolescents can be considered a normal developmental process because they outgrow it. Some risk-taking behaviors lead to serious consequences, while others can be corrected. It is also imperative to note that risk-taking behavior varies with cultural factors, individual personality, the needs, social influences, pressures, and available opportunities. So here, risk-taking should not be confused with rebellion. Rebellion involves moving away from their parents. Risk-taking is about moving towards something without thinking of the consequences. Of course, sometimes the line differentiating between the two can be murky. So adventure is a calculated risk where one does something out of the realm of routine in a novel way with creativity and planning. Of course, they require practice and a lot of skills. The adolescents often take risks without being fully aware of the consequences. They can make poor decisions, but that may put them at risk and leave them vulnerable to various hazards. By understanding them and their vulnerabilities, the adolescents have to be given the life skills that empower them so that we can cater to their needs. The clusters of risky behaviors, two of them are smoking will go on to alcohol, then drug abuse, go on to the sexuality part of it. So depression will perpetuate suicide. So these two are the clusters involved. So what are those behaviors like substance abuse, as I said, sexual behaviors, which contains the unwanted and unsafe sex, sexual abuse and exploitation, infections, teenage pregnancy, school failures and dropouts, living on the streets. Of course, accidents and injuries are very common. Adolescent suicide and depression is very common for trivial reasons, just for love affair, love failures, violence and aggression. So the others are dangerous driving, unhealthy eating, running away, staying away all night, unprotected sexual activity, selfie in dangerous occasions, shoplifting, gang violence, weapons, bullying, dangerous dieting. So the brain development during adolescence is required to be known first. So we'll go into this study by Christian Ferg and Peter. Findings in the developmental psychology and neuroscience reveal that a fundamental reorganization of the brain takes place in adolescence. In the postnatal brain development, the maximum density of gray matter is reached first in the primary sensory motor cortex, and the prefrontal cortex matures last. So the subcortical brain areas, especially the limbic system and the reward system, develop earlier. So that there is an imbalance between the more mature subcortical areas and the less mature prefrontal areas. So this accounts for the typical adolescent behavior patterns, including risk-taking, totally so many other adolescent behavior patterns, including body image and so many other factors. This is the basis. The adolescent brain maturation is the one that contributes to it. So these adolescent brain maturation, which involves the interplay of two networks, the socio-emotional network, which is sensitive to social and emotional stimuli, which is particularly important for reward processing and is remodeled in early adolescence by the pubertal changes. They are localized in the limbic and paralimbic systems, limbic areas, the amygdala, ventricular striatum, etc. And so the cognitive control network is the other network which develops later, which observes the executive functions, planning, thinking ahead, self-regulation. It matures gradually. So this is situated in the outer areas of the brain, the lateral prefrontal and parietal cortices. So the nature of the adolescent depends on the interplay and interaction between these two networks. The balance between, because the adolescent is emotional, so vulnerable because of these delayed maturation of the cognitive control network, usually by 21 to 23 years. So in this graph, you will see that the limbic areas is, because the limbic areas is prone initially, so they develop earlier. So the prefrontal cortex develops later. The risky phase is there. So the maturation process in between the two leads to the imbalance. So the time-lapse brain here, the gray matter wanes as the brain matures. So from age 5, you can see gradually at 20, you see the MRI sequence of the brains at the age 5 and age 20. So the following image shows that the brain doesn't change much in size between age 5 and 20. Only the changes in the color. The blue color shows that all the connections happening between all parts of the brain that are already formed. So the recent MRIs have really revolutionized the scientific thinking by emphasizing the neurobiological underpinnings of human adolescent behavior, in addition to the numerous psychosocial explanation of behavioral change according to Steinberg et al. So, because of the imbalance in maturation of these two social networks, the adolescent is confused and concerned and really vulnerable. So they have a very problematic peer relationship, and due to peer pressure, they do all sorts of risky behaviors. The relationship with parents is actually questionable, and they move away from parents, go towards the friends, and the gender roles, of course, they have to orientate with them. The self-esteem declines. The media influence is always influencing them always. The influence of peers on this risky behavior in this graph, you see that when they are alone in the early adolescent, you can see it is less. But as the peer pressure increases, the early adolescence is vulnerable. But the other age group, we can see a decreased risky behavior. So the reason for the risky behavior is the lack of skills necessary for adulthood. Working and communicating with others, they are not able to understand themselves. They make because of their indecisiveness. So life skills in adolescence are the skills and competencies needed to build or adopt positive behaviors that will enable them to deal effectively with the challenges of day-to-day life. So this is a study for the risk-taking behavior among adolescents and their attachment with parents and peers. The results shows that females were more attached with their parents and peers in comparison to males. The sexual activities were found to be higher among males than females. But nowadays, I think it is the gap is being narrowed down. And of course, I think it is becoming equal. We require more studies. It was found that in females that the desire of indulging in substance abuse and sexual activity was low. But the practicality is the other way behind. So thus the positive peer pressure was found helpful in keeping females away from risk-taking behavior. So here the early adolescence is singled out as a critical moment of opportunity for building skills and positive habits, since at that age there is the early development or the starting of the development of abstract thinking. Till then they were concrete thinkers. So they will start to understand the consequences and try to solve problems. So the life skills will translate into positive behaviors that promote health, mental well-being, and good social relationships. So the most important life skills are here to avoid risk-taking behavior are assertiveness and decision-making. So what are the domains where the maladaptive outcomes of the risk because of the risk factors? In the individual domain, you have, because of the personality variables and developmental delays, you will have problems. Family, there's a family conflict, mental illness in the family, coercive parenting always, you will have this risk behaviors. The peer rejection and deviant peer group membership will have problems. The school, in the school, they will have this academic failure or a low commitment to the school, and community will also be responsible, what community they are in, the neighborhood. Poverty is also a problem concern. So protective factors for protecting them from not indulging in risk behaviors is the strong sense of connectedness to parents, family, school, community, institutions, and adults outside the family. So this will protect them from involving into risk-taking behaviors. The development and enhancement of academic and social competence, the involvement in extracurricular activities that create multiple friendship networks will be a barrier. So spirituality and prayer definitely will help the adolescents. So the assessment of the risk-taking behavior will be by the heads interview. So the management part of it will be adolescents should develop good assertion skills so that they'll be able to say no to anything unethical. They should decide to say no to drugs and premarital sex. Adolescents need an environment that gives nurturing guidance, rules, structures, clear expectations, and consistent limits. A safe and supportive environment motivates them to make healthy choices. Safe means absence of trauma, violence, and excessive stress and abuse. Supportive means that which provides a positive and close relationship with family, other adults, and peers. So the pediatrician's role, they should play a careful attention for a comprehensive risk assessment, because these behaviors are associated with prediction and intervention of risky behaviors. They have a unique opportunity to intervene, to prevent and treat risk-taking behaviors. They must spot it, assess, refer, and manage problems, assist in fostering parental skills and interpersonal skills, guide in activities for school, peer groups, religious involvement, maintaining family events and rituals. They must focus on healthy and safety while assisting with healthy lifestyle choices. So gather approach for counseling. This is, will be dealt later, but we'll have the basics. Ensuring confidentiality and privacy is crucial for all counseling sessions. Must greet the client, ask questions effectively in a friendly manner, tell the relevant information to help them reach a decision and make an informed choice, help the client to reach a decision and give other related information, explain about the method in detail, and when to return for review should be told. So the therapeutic interventions to reduce these behaviors are skills development, incorporating problem solving and decision making and negotiating, managing stresses, failures, and anger. So prevention will be expanding the adolescents' access to mental health and contraceptive services, raising the driving age and strict tests to issue licenses, limiting adolescent smoking, substance abuse, teenage pregnancy, and automobile accidents. So vigilantly enforcing laws and sale of alcohol. What are the roles in schools? A structured program with flexibility and evolving content in schools for early adolescents around 10 years of age and extending to 18 years old. Schools should impart formal and non-formal education. They must increase the co-curricular, non-curricular, and cultural activities. So what parents can do? Reinforce and support the desirable behavior, give many chances to learn and practice positive behaviors and skills. Provide effective instruction in academic and social aspects. So monitor and be involved. Monitor adolescents' daily activities, listen to the youth's ideas and concerns, make clear rules and gently and consistently enforce them, set limits on screen time and media content, structure positive sibling and peer interactions, guide youth away from troublesome peers. So what are the 7 feasible strategies? Support and strengthen family functioning, increase connections between students and their schools, make communities safe and supportive for children and youth, promote involvement in high quality out of school time programs, promote the development of sustained relationship with caring adults, provide adolescents the opportunities to build social and emotional competence, provide them with high quality education. So life skills are very important for the adolescents. They are the abilities for positive and adaptive behavior that can enable them to deal effectively with the demands and challenges of everyday life. So the positive thinking and self-control have to be inculcated. The life skills framework consists of thinking, social, and negotiation skills have to be taught. The whole gamut of life skills. Leadership skills, assertiveness, and negotiation will be effective for the professional life later, or the 10 core life skills should be inculcated. The parents, teachers, and significant adults should know about these life skills and teach the adolescents and give responsibility and freedom to the adolescents to devise their own life, and empowering the adolescent is important. Thank you for the opportunity, and over to Swati ma'am for the practical suggestions.
Thank you, Dr. Santil. Thank you, Dr. Ismail, for having invited me for the Tamil Nadu State Conference. And I thank Vijayarani for a very affectionate introduction. Now, a beautiful lecture. You have really covered all aspects, and there's nothing theoretically which I can add to a lecture. And you had asked me to talk about how as we can prevent high-risk behavior. So I'm going to talk about that. And Ismail has asked me about practical tips. So I will discuss how do we approach a case of adolescent who has brought up a risky behavior by their parents. So first of all, as pediatricians, we know that we have to increase community and parental awareness. Majority of parents as well as the students themselves do not know about the adolescent brain development and the vulnerability to adolescent risk behavior. And though we think they know about drugs and smoking and alcohol, We have been doing a lot of programs in school for the last 30 years, and we do the before and after workshop surveys. And we have found that most adolescents really do not know in depth the dangers of having alcohol before the age of 21 or smoking before the age of. So when we go and teach adolescents, parents, and teachers, what we want to give them is age-appropriate messages, depending on their early, mid, and late adolescence, and depending on concrete thinking. And what we highlight, just as we talk of abstinence, we tell everybody not to have sex, but we know that many of them are going, and then we talk of safe sex. Similarly, when we go to schools, can you hear me or shall I change my internet? Can you hear me properly?
Yes, madam.
I think hear me, no? Just wave like this, then I change my connection because I'm getting some unstable connection message.
Yeah, bandwidth is low. If
possible, shall I just change? I'll just change it. 1 second. Can you hear me better? Is this better? Yes. You can hear me?
Yeah, you're audible, madam. You can go, but the bandwidth is low, but you can still go.
Okay, I'll just try another one. 1 minute. Can you hear me better now? Is this better?
Yes, ma'am.
Yes. Okay. So what is most important is that most children are not aware of starting smoking early, like nicotine receptors proliferating, which can make them chronically addicted for life. Majority of them think of smoking only as cancer. And if you tell them that nicotine affects every artery of the body and it can cause erectile dysfunction and other aspects, that really makes them understand about the smoking. Similarly, when we talk of alcohol and teenage drinking, when we explain to them that teenage affects the hippocampus, and MRI studies have shown reduction in the size of the hippocampus when they do teenage drinking, which can affect the academics and their memory. So if give them scientific evidence that by starting drinking or smoking before the age of 21, the damage which happens to their body and their brain is very long lasting. That is a better way of telling them to not to start smoking and drinking early than just tell them abstinence, don't smoke and don't drink. And we found that this method helps a lot. So we do a lot of discussions on tobacco and alcohol prevention by starting early. Second, we also talk about the parents and teachers have a myth that if you give them sexuality education or drug abuse education, they'll be tempted to experiment. Whereas research all over the world has shown that when they get this knowledge, they're more likely to delay experimenting, whether it is sexual or drugs or alcohol. And I think we have to now teach people about the bad effects of drugs in very great detail, especially date rape drugs and what can happen with the filming and the blackmailing. So I think very open communication with the permission of the parents and teachers in school is the only way to reduce risky behavior. Am I audible? Yeah. Now, do all adolescents go through risky behavior? No, because we found that though adolescent brain is very much vulnerable to risky behavior, majority of adolescents, Aram, are you able to hear me or not? Is there
yes,
a problem?
ma'am.
Okay.
No issue.
Okay. So majority of adolescents who come from a stable, connected family, from protected communities and good schools, do not enter into such a risky risky behavior. Majority of them may experiment, but they don't have very serious risky behavior. So which are the adolescents which are more likely to have risky behavior? Aram has very beautifully said the risky factors both at community hem. Let me give an approach when parents come to me with a child who has got repeated complaints from school and community of high-risk behavior. I first take a very good family history because we have to look for flag signs. Are there some organic problem in this child which is making him go into recurrent risky behavior? And very often in my 30 years of practice, I have found that these children may have ADHD, they may have impulse control disorder, may have conduct disorder, they may have oppositional defiant disorder. So giving a good psychiatric analysis of a child who goes into recurrent risky behavior is very important. because unless we treat the basic disease, any amount of counseling and trying to prevent high-risk behavior will not be useful unless we combine with a psychiatrist. If from the head's history and the family history, I find there are no flag signs for any mental health issues, and this child is just a child who's quite normal, but prone to thrill-seeking personality, and then we try to find out what is he lacking in his life? Why is he going for this recurrent risky behavior? And so we find, has he got low self-esteem issues? Is because of that, does he get vulnerable to peer pressure? Does he have depression? Because in that, they try to soothe themselves by risky behavior. So you go into an in-depth analysis with head's approach and the family dynamics as to the root cause of why is this child indulging in risky behavior, because that is the only way to prevent further risky behavior. One thing I would also like to tell them that very often in many families, the parental role model is very bad. And that provokes children into risky behavior. I'll give you a simple example. I had a very sad case where a boy was brought to me for insomnia. And the parents were all bothered, ma'am, give him sleeping pills, he's not sleeping. And I said, but why is he not sleeping for the last 3 months? They said, no, he had some incident in his life. What was the incident? This boy, who was only 16 years old, drunk and driving, drove his father's ambassador and completely totaled it. Now, the parents were not bothered about the drinking behavior and totaling of the ambassador or the Mercedes. When I started talking to them about it, they said, ma'am, it's okay. We are rich enough. Fortunately, he didn't kill anybody. We can afford to buy a new Mercedes. But I said, aren't you bothered about his drinking and driving? He could have killed somebody. They said, no, ma'am, all his boys of this age do it. And his friend is a police commissioner's son. So they get away with it. Now, if you have parents like this, who are not concerned that their child is doing underage driving and that he's even causing accidents, you can imagine how difficult it is going to be to counsel this child not to have high-risk behavior. So we have to go into deep history of the parental behavior. Are they having risky behavior? Many parents do crossing of the signal, driving without license, and they say you just give 100 rupees to the policeman and everything is done. So law breaking and risky behavior is a role model at home. So abroad, if your son or daughter do underage driving or drinking, the parents are punished, because how did you allow the keys to be lying around for the underage driving of your children? So role modeling by the parents is extremely important. And if the parents do not bother about the law and order situation of the country and they themselves break laws, then the children are definitely going into high-risk behavior. If you have a bar which is continuously open, if you're going to drink every day, it's very difficult to tell your teenager son or daughter not to drink. So role modeling by parents becomes extremely important to avoid risky behavior. Secondly, we have to know that open communication between parents and children is very, very important. Most parents are very judgmental. So if a child comes and says, you had told me not to smoke, but I did try a cigarette today. Or you had told me not to drink, but I did have a glass of beer today. If a child is able to communicate to the parents that I did this risky behavior, and the parents do not then start castigating and scolding him, but sit with him and say, let us analyze that though you know that this is bad, why did you feel tempted to do it? So that you can analyze, so that next time the child is tempted, he can take care that, yes, last time I was tempted under various clauses, but next time I can control myself and not do it. But majority of the children are very afraid to tell their parents if they have done something like this, because the parents either will scold them a lot or immediately stop their access to parties or drinking or driving or whatever it is. So it is very important for parents to be there to tell their child that you should not do risky behavior, give them the life skills to prevent it, but at the same time tell them that we are here for you. So if you do some risky behavior, only we can help you. So please come and tell us. And of course, you are not going to cover them up. For example, if they are going to have a challan, you are not going to bribe the policeman, but we have to pay the challan, so they understand that yes, when they do some illegal act or when they break the law, they have to face the consequences. But they will, you'll of course try to find a good lawyer for him if he has done something which he has come into trouble. So basically, parents have to be role models, that they do not show risky behavior, which is condoned by them, where the child will also do the risky behavior. If there's any flag signs of mental health issues, we need to work as a team with the parent, the child, and the mental health professionals, so that the risky behavior which is due to a mental health problem will be corrected only if we treat the mental health problem. Only counseling is not going to help. And the other thing is that risky behavior increases their prestige in the peers. The more likes they get, the more dopamine release they get. So we have to see that you can do something else which is sensational but not risky, which will give you a lot of accolades from your peers. And these are achievements. These are achievements in sports, in academics, in talents. So we can tell them that you can get your thrill, you can get your dopamine by doing something extraordinary in a positive way. And you don't have to do these dangerous TikTok dare movies. You have seen the TikTok movie where two people are standing and they ask a guy to come in the center, and both of them just kick him and the child falls flat on his occiput. And we had a lot of serious head injuries after these TikTok videos. So there are a lot of TikTok videos which are going around, which have serious dares, which can really be harmful. And we have to talk to our children that don't try to have such high risk things just because you want to make a TikTok video, which will give you a lot of up likes. So this is more communication with parents and their children, and adolescent expert like us to go and communicate with parents and children to say that high risk behavior is not fun. It can damage you. It can damage your friends. We can show TikTok videos which show such dares and say, please don't attempt it. Have I got some more time or shall I wind up?
One more question is about this dating and other aspects, relationship with among teenagers.
What do you want me to say about
dating and group dating and individual dating, and how they are how they are going about the relationships?
Okay. So one thing, remember that most parents just stop their daughters not going for overnight picnics, not going for outside things. They never sit and literally discuss. Why are they afraid of overnight picnics? Why are they afraid of the girls staying away? Why are the girls, the date rape drugs, the gang molestations? All this has to be discussed in detail. And the girl has to be told, we trust you fully. It is not that we don't want you to go out and enjoy. But these are the risks, and we are worried about the concerns of your safety. So if the girl can follow 5-6 points, that means her parents know where she's going. Her parents know which are the other phone numbers they can contact in emergency. If her parents know who is the adult supervision, if they know exactly what is the venue, if they know who all are coming, then the parents will feel much more safer to give permission. And date rape drugs needs to be told, and this is very, very important. Now, Aram, you were asking about premarital relationship. Now, premarital relationship, frankly, we have to start with abstinence, because we have to explain to them that they're not emotionally, biologically, mentally still ready to face the consequences of early premarital sex activity. At the same time, we have to be practical, because today's young adults are exposed to a lot of sexual contents on the digital media. They've got early puberty. They have very delayed marriage. They're getting married up to 30 plus. So it is not practical to expect that the young adults will be totally free from premarital activity. But we have to explain to them the pros and cons, that if you have a relationship which is only platonic, only romantic, only very emotional, how is the consequences, versus a relationship where you have gone into physical intimacy. Because very often these children have very transient relationships, and they may have 2, 3, 4 relationships. And if they have gone into a physical relationship, the consequences are much deeper. And it is much difficult for a person who had a lot of physical relationship to enter into a stable partnership after marriage. So what we have to explain to them, what are the consequences of a relationship which is non-physical? What are the consequences of a relationship which is physical? And we have to leave the decision to them. And our job is to tell them the pros and cons. But if we start telling them premarital sex is bad, you should not have these things, you should not have affairs, all this is not going to be acceptable. Our job is to tell them what is the pros and cons of each relationship, and we have to leave it to their judgment and our upbringing.
Excellent.
Well, your comments.
Yeah, thank you, Dr. Senthil and Dr. Swati Bave. Of course, Madam, you proved your class. And really, it was an eye-opener. What I expected was this. A practicing pediatrician need to motivate the parent. He has to open up with the kid. We are opening up, we are saying, we are restricting him from the activity. It doesn't going to work. I think you should have to sit down and open up and tell the pros and cons, what are all going to be the ill effects. Then only the kid will also understand, and the parent will also have a licensing and the good relationship with the kid. Excellent, madam. Excellent. Kudos. And Sandil, of course, you did a wonderful job. I think the slides, both the slides, what a pediatrician should do and what a parent should do. This is all what is meant for a practicing pediatrician. Both these lectures were totally practical, and I'm very happy. Thanks to both the speakers. And I pass on to Sandil to go for the next session, please.
Yeah, the next session will be on mental health issues by Dr. M. Vijayarani, who's a renowned adolescent physician from Vellore. She's got her own child guidance clinic, and she's doing a wonderful job in Vellore for the past 15 to 20 years. So rich in experience. She's going to deal about the mental health issues. And the expert for this session is none other than Dr. Preeti Galagali from Bangalore. She's a great teacher, a great inspiring adolescent physician who is so knowledgeable, and she has done so much work in adolescent, and she has been the chairperson of the Adolescent Health Academy in the CIAP, and she is going to be the expert of this session. And with these two stalwarts, I hand over the mic to Dr. M. Vijayarani. Over to Dr. Vijayarani.
Thank you for a nice introduction, Dr. Chandra. Thank you. So the next 15 minutes will be on just a bird's eye view on mental health issues in adolescents. Today, our IAP president's quote, the world as we have created, it is a process of our thinking. It cannot be changed without changing our thinking, by Albert Einstein. This is a very important quote. This thinking is also changing as we unravel more about the adolescent brain and neurobiology. So as we go, we will see this has to really change how we had been handling our adolescents in the past and how we have to handle our adolescents from now on. So we will be seeing mental health in adolescents, the disease burden, issue as such, neurobiology, factors responsible for mental health disease, prevention, approach to a case with mental health disorder, and case presentation. If you see this study by Niemans and also published in Lancet, two studies, where the numbers are so high, 9.8 million teenagers, 13 to 17 years suffer from depression, other mental disorders, who need active intervention. And without saying, we all know suicide ranks first in the cause of death among adolescents and young adults, and 30% of the world's suicide is in the area, India and China, where the young people are involved. And the onset, by 14 years, 50% of the adolescents have mental disorders, and it is our responsibility to diagnose early. And the average suicide rate is 10.9 among lakh of population. If you see the other all the mental health diseases like schizophrenia, depression, dysthymia, bipolar, panic disorder, generalized anxiety disorder, and so many other, OCD, everything, only 50% of the disorders are diagnosed, and other 50% need active intervention also. Apart from this, we have internet addiction disorder, which has not come under this study, and alcohol abuse, which most of them are not under treatment, smoking and alcohol. And apart from this, again, the special children who are having mental health issues, that is really uncared for. So the pediatricians have a great responsibility, especially the people who are trained in adolescent medicine. What is so unique about this area? Like everybody who so far who have heard, we all know there is so much of developmental changes that is taking place both physically, mentally, and psychosocially. We have different phases, early, middle, and late adolescence, even moving on to the later phase of young adults. And there is a maturing brain, which is really complex, and only in the 1990s, and also after the invention of functional MRI, we are able to understand the brain, where a lot of pruning is taking place. You saw the brain pictures where the gray matter is pruned and fresh nerve connections are being done in Dr. Chandal's slide presentation. And also the development, the physical, mental development, and what is happening around. It is asynchronous. Physically, the adolescent may be grown up, but mentally he is not mature enough for that amount of physical growth. Again, he or she is not that much mature enough to deal with what is the demands of the society or the psychological issues. They have to wait. Along with that, we have the academic demands, which is unique, and this is of the century, where we are putting extreme pressure on the kids to really perform well. And the peer pressure, global phenomenon. All the children want to mimic each other and to recognize themselves along with the other adolescents. And relationship with parents is becoming very tough. It had been always so, but it is even more tough with the pressures. And this is something we need to think, we should be aware of, that there is a second window of opportunity. There is, at one end, there is a rapid learning process, brain development taking place, pruning is taking place. At the same time, the brain is also vulnerable, which we must protect the brain from the bad effects. And what is this another chance? Not only on nutrition and growth, it is also for the pediatrician to recognize early and manage mental health diseases according to one's training. What is the role of primary care pediatrician? We must understand that we are family centric, and family has a powerful influence over the growth and development of the adolescent. As well as the parents have more responsibility towards the adolescent care. As ma'am said, they have to do role modeling. So every opportunity, the primary care physician, pediatrician must emphasize on this role. And why we have to take it upon ourselves is, you can see the 0.3% of psychiatrists and psychologists are available for 1 lakh population. And every year, the amount of mental health disease is becoming a bigger burden. The numbers are increasing statistically. And adult psychiatrists, they tend more to the adults predominantly. And to commemorate their, for raising awareness and mobilizing support, we have October 10th as the Mental Health Day. Our role is to do early detection, screening, and management are optimum to our training. And they must treat the mental health diseases, what can be done at the primary level, and refer to other specialty. It's a teamwork. It is not that the pediatrician and adolescent physician work solo. We have to work along with the psychiatrist, psychologist, and social worker, and counselors, and other speech therapists, etc. The various systems, we only know about the adrenergic system. We always, right from our medicine time, we had been taught about fight or flight. But only in the 1950s, 60s, and 1947, around that time only, we started understanding or discovering about the serotonergic and dopaminergic system, along with the cholinergic, GABA, opioid, and glutamate system. See, it is not only stimulatory, we have to understand it is also inhibitory. There must be a balance between both the systems, which is stimulating as well as inhibitory. And why adolescence is a time of true wonder. You know, in Tamil they say Vasanta Kalam, and most of them will have beautiful memories of adolescence. During this period, there is a lot of maturing brain, and there is high potential for intelligence, emotional intelligence, as well as the other kind of multiple intelligence. But what is happening is the brain is not maturing uniformly. The limbic system, which is primitive and which is the older part of the brain, matures first. And that is really the part responsible for the emotions, like the amygdala and caudate nucleus, etc. The myelination which is taking place is from the occipital towards the parietal and the frontal and the prefrontal areas. Again, the neocortex is getting myelinated or maturing later. And whatever had been learned in the childhood, which was not used, is going to be pruned, and fresh networking is going to take place. And every one of us must have this in mind. And I also tell the parents, and the adolescent, this is the greatest opportunity to improve their mental faculties. There is new network connections along the various neuronal pathways, and the most important, the reward seeking, the happiness hormones, the why risk-taking behavior is so much in the adolescents. The happiness, the reward that gives him pleasure, pleasure-seeking behavior, that we must be aware of and gently divert from the high-risk behavior to the other behaviors what Swati ma'am had told. Potential for high skill building. Yeah, this high-risk behavior must really be converted to high skill building. And the coordination, we must understand that must be graded, where we have this networking to the, even to the cerebellum, which is very important for the body coordination. We should not, that is exactly why we should not, the licensing of the two-wheelers, we have 18 as a cutoff. All this we must keep in mind and educate the adolescents. Why we are asking them not to indulge in those behaviors and why we are delaying them to drive a bike. Unless we tell them, they just think we inhibit their independence. And the neuroplasticity is double-edged sword that will go towards the where we want to, like positive or negative. It is very plastic. If you pull into the negative, then there is more networking going towards the negative things we are going to put into our brain. So it is a double-edged sword, and human brain has always evolved for survival. This is part of the limbic system, the basal ganglia, the thalamus, the amygdala, the hypothalamus, and hippocampus. Each area has its own importance, like memory, thalamus for sleep and consciousness and alertness, which is very important, fight and flight. And amygdala, it's important for emotional response, very sensitive. And that is why we can see the mood fluctuation, the exaggerated emotional feelings of the adolescents, and which when it is losing balance, that is when the mental health issues crop up. And the hypothalamus, which controls everything. The hippocampus is important for memory. We must understand it has a lot of connections with the prefrontal cortex as well as the other areas of emotions. Just to highlight a little how much we have memories of the Mumbai blast and the Taj burning, and what kind of emotion it invoked in us. We correlate that emotion with the burning of the Taj. So memory is very important. The good memories, good feelings, and it connects to the prefrontal cortex and the higher center, executive functioning. It will really aid the adolescents. Okay. What is the causation for the mental health problem? Just to highlight a few. All of us know about the genetic inheritance. Every one of us must be having some mental health gene hidden in our genetics. But we must also be aware of the epigenetics. That is through generation, if you are going to promote the negative, like any depression or anxiety problems, promote the mental inclination to these mental involvement in our system, then it can affect a future generation. Like for instance, if the mother is going to be very anxious, there are studies saying that the child also tend to be anxious. And the psychosocial factors are many, like maternal deprivation, pathological family patterns, which is very much, which we must get into the details and can help in some of the preventive factors. And disordered interpersonal relationship, very, very important, where we have to work on the life skills of the adolescents. Key stresses of modern life. We have to be grounded. Like during COVID situation, we saw how so many positive effects were also there. Along with the negative impact of the COVID on the health system, there were so many modern on the modern life, where the families were together, cooking together, learning new skills. All these things can be avoided. Same thing can be projected to a deserving adolescent. And new studies are coming on gut microbiome neural connection. There are a lot of serotonin receptors in our gut. So this also we must be aware in educating our adolescents and the parents on healthy eating behaviors, how all our food, the fruits and vegetables, the fibers, all these will play a greater role rather than the junk foods. And fetal origin, all along we had been talking about Barker and low birth weight and cardiovascular disease. there is some insult to the brain and also stressors which can affect the fetal brain and later can result in these mental disorders. So how to involve the parents as well as the adolescent? What can we do as primary care pediatricians and physicians to tell to adolescents and preventers to do some preventive aspect in mental health? Connect with people. A man is a social animal, not to forget that. Always to be in the amidst people, friends, and talk with them. It gives lot of self-esteem and recognition to belonging. You belong to the people. And also sometimes it helps in sharing of emotions and sharing of distress, and they can give us some support. It is very important. And also physically being active, the dopamine that is going to be pumped whenever one is physically active. Not necessarily they should be in a gym doing. They can do other normal active instead of, I have seen adolescents not doing anything at home, but daily going to gym. So we must integrate these kind of physical activity in a routine life. And also the other kind of, which will be very happy, which can give happiness, like getting engaged in a game. Like if they are interested in a throw ball or a volleyball game or something, or swimming, something new. And eating healthily. Time with the family is very much compromised. We know the internet has taken over and screen time has really taken over. Not only adolescents, I think every one of us who is watching this program today. That is very important. At least some dinner time can be together, or whichever time is suitable for the family. And also the communication, actively listening to the adolescent can give us clues to pick up any mental health problems or sharing of the difficulties. So these things must be emphasized, which enhances positive mental health. Learning new skills. We should not restrict the children. I see very academically oriented kids. Some of the parents, they don't let them do learning other new skills. That must be encouraged. Act of kindness, volunteering for charity work or any other general work in the community. There is a lot of thanking and gratitude from other people will really boost the self-esteem and give some amount of pride in doing those activities, and inversely and automatically help in mental health and mindfulness. We must be grounded and really oriented to the present, what we are doing, rather than worry about the past or worry about what had happened already. And in positive mental health, there were so many studies and which were done. They found the most important, which had really made a change in mental health disorders, was improving interpersonal skills, emotional regulation, alcohol and drug education. So every time we must, in schools and even while talking to parents or individually in adolescent, we should be concentrating in these areas like emotional regulation, like for example, anger control, or interpersonal relationship, how to communicate, how to talk, and how to express the feelings. These can be done. And these are some of the pathways, happiness and how mesocortical pathway. It is the two brains, the thinking brain and the emotional brain. There are pathways getting connected. We must wait for the maturation of the prefrontal cortex. What are the mental health disease or common mental health disease? There's so many. It is very difficult to speak about all these things in 15 minutes, but we must be aware all these diseases are there which are neglected. And the recent ones, like Dr. Mona said, eating disorder, very important. They are seeing a lot of cases. Internet addiction disorder, very important. There are so many classification. DSM-5 has included the classification, and we have screening charts, how to diagnose, and substance abuse is rampant. So how do we approach a case of mental health problem? General medical checkup we have to do. That is a must, and that doesn't mean adolescent we do something else. We have to do a general medical checkup. And other organic diseases can present as mental diseases like hypothyroidism, Wilson's disease, or any other drug-induced problems can be there. HEADS is a must for which is a psychosocial review. It needs around 30 to 40 minutes. It gives entire history taking, and you can pick up very nicely the problem areas. Then we screen for the risk behavior and assessment, management at the primary level, what the pediatrician is trained up to, and then referral. When you think these are cases that must be referred, we must refer. So how do we go about this? So a good HEADS review, it will pick up all the red flag signs as early as possible. Like what is HEADS? Home environment. What is happening at home? Is it a nuclear family or a joint family? Who are there? Or is it a single parent, or the child is living, the adolescent is living in a hostel? That gives an idea how next we have to put our questions or what to expect if a child has a single parent. Next is the education and the employment. We should not take these for granted. The child, if we see an adolescent in our setup, definitely they must be going to college or school. Eating is very important. We must take a lot of thing, and activity what the adolescent is doing as a pastime or a hobby. So we should make a note. Never forget to ask about drugs. Gently the question must be put, like, is any of your friend, any of your friend who's smoking or into alcohol? And then you can lead the questions to in-depth questioning if you have a suspicion on that, or if you think it is necessary for that adolescent. Sexuality, don't take anything for granted or don't hesitate. You must improve your comfort level and then ask question, or you can have a questionnaire. And we must talk about girl-girl relationship, boy-boy relationship too, because keep that in mind always. Suicide and depression, we must ask for the moods, and also we must really be aware of what is the normal level of the mood. Is it okay? The adolescents are having mood fluctuation. Is it normal or abnormal? Correlate with other signs and symptoms of depression. Also ask for anxiety symptoms and other OCDs and internet screen time, etc. Safety, we must ask about safety, whether they wear seat belts, whether they wear helmets, and if you feel they drive during taking alcohol, or if they go in the car driven by a friend who is under the influence of alcohol, you have to do the other screening tests like that. Spirituality must be integrated. They helps a lot in our further guidance, and that must be part of life. Doesn't mean it's something pertaining to any particular religion. So after doing a head screening, if there is no risk, or if you think everything is fine and smooth, this is the right time to do anticipatory guidance, because the adolescent is with you. Then if you pick up any risk factors, then you have to do the screening according to the signs picked up. You also have the strengths and weaknesses assessed. So you can use these strengths and weaknesses during the counseling session, that you can say, see, you have so much of interest in sports. Why don't you do that? Why don't you join yourself in any sports academy? Things like that. Or drawing skill, do some art classes and engage yourself. Right? Counseling must be part of every pediatrician and adolescent health consultants. And I know most of us are good at it, because all along we had been doing this, and just that a little different with the adolescents. We must always, there are some skills told by Dr. Chandal, yes, we have to have all the attributes of a good counselor. And when it is not under our purview, then we have to refer the case. Screening of mental health disorder, plenty of screening, which is standardized for Indians setup. We have many screening inventories, like Beck's depression inventory, suicide ideation questionnaire, SCARET for anxiety disorder. Then you have new ADHD rating scale, internet addiction disorder, CRAFT, teenage addiction, severity index. So many, each thing. Even for bipolar, you have self-assessment screening tools. So many things are there we need to read up. 100% we must refer immediately whenever an adolescent has suicidal ideation. Don't think we can handle this adolescent. We'll try to counsel. We might be in surprise if suddenly we hear the news of the death of the adolescent. All psychosis must be referred. Severe mental diseases, severe substance abuse, and if they are not poor response to counseling, must be immediately referred to the specialty. So with all this in mind, in your routine practices, if we see, there'll be a different kind of presentation. See, I saw this 15-year-old Radha who was brought by the mother with complaints of low mood for 2 weeks, loss of appetite and reluctant to study. This mother was very worried because previously this adolescent was very happy going to school and cheerful adolescent. On detailed history taking heads, and then there was nothing much to worry. There was just that the adolescent was in the middle adolescence and having an acne. And there was a single pimple that she was bothered and always spending time in the mirror. And she was not happy about this and being teased about her friends. So that really put her off, and counseling and giving her, telling her this is a normal hormonal change. And then it can be treated, and other strategies was given to this adolescent. And there was nothing much, but you can make a note of it. And this is just a normal passing of the adolescent. We need not imagine immediately if is the adolescent having a body image problem. Again, another Ajay, 15 years old, with weight 40 kg and 150 centimeters height, was brought by their parents with low mood and refusal to going to school. Here on history taking, and what we were able to assess was that the centiles are okay for the adolescent, was in the middle adolescent. Just that he was fitting well, then he has to understand all his peers in the class were taller than him, and he was short, and he was bothered, and he was bullied in the school for that. So we have to tell him we have to take mid-parental height and assess the parents' height and chart the height weight charts, and be confident about the height velocity. And he has to tell him that peak height velocity is yet to happen, and then we have to giving some assurance like come for after 3 months, and also how to tackle his bullying in this school, and that is he needs to wait for his growth, and if he has more trouble he can come and talk again. So the adolescent was happy and there was no episode again. So is this all for adolescent? What are the mental issues? So we will be seeing what are the mental health issues in detail by Dr. Preeti Galagali. And what I would impress upon the pediatrician to give to the parents, building resilience like this fort is very, very important in mental health. So what are all the skills, whatever is available, we must give to the parents as well as the adolescents wherever the opportunity arises. Parents must be a role model, and we have to give positive everything positive, like unconditional love and appreciation, and we have to tell them about the happy hormones and positive mental health attitudes. Thank you very much. Over to Dr. Preeti Galagali.
Can you see my slides?
Yes.
Not yet.
Not yet?
Not yet.
Oh, so it's coming here. My screen sharing is paused. Okay, I'll try again.
Yeah.
Can you see it?
No, you have to wait a few minutes. No.
Okay, because it's coming here, your screen sharing is paused. So I wonder if there is something thing from there.
Dr. Thiru, you're there? Dr. Thiru?
I think it's not there.
Because it's coming here, screen sharing is paused.
Madam, you can try once again, madam.
Okay, once more I'll try. Yeah, can you see that?
Yeah, okay, just wait. Yeah, it has come, madam.
Okay, okay.
It has come now. Yes.
Can you all see?
Yes, yes.
Okay, okay. Thank you, Dr. Vijayarani. That was a very elaborate presentation. Actually, I don't think I have anything more to say. So you know what happens when an expert speaks before an expert. So anyway, let's go through this quickly. I hope that after my presentation, all of you would feel that you can manage adolescent mental health issues in clinical practice. Because if we do not have this approach, we know that if we do not manage these issues in adolescent, they can lead to an emergence and re-emergence of non-communicable diseases and other mental disorders in adulthood. So in the next few minutes, I'll go through a few practical pearls, talk about the influence of COVID-19 on adolescent mental health, and what is the role of pediatricians in mental health issues. Now, coming to a few practice pearls right in the beginning, important thing for us to develop a adolescent-friendly clinical practice. It is good clinical practice that we as pediatricians begin to see any child coming to us over the age of 10 years, a few minutes alone, even in a busy OPD. It could be even for a few seconds. This would convey to the parents that all adolescents do spend some time in private with their pediatrician, and this would help you to build up rapport and therapeutic alliance right from early adolescent age group. The second thing is, it's a good idea to have a few hours, probably on one weekday, exclusively kept for adolescent practice. Of course, the inclusion of head psychosocial history into your clinical weaponry. Also, when you discuss the management, remember to discuss it first with the adolescent and then with his permission with the parents. And important to partnership with the parents, schools, peers, and also other adolescent health professionals and mental health professionals and professionals from other specialties. So as Vijay said, that normative psychosocial development can sometimes confuse and present as a mental health issue, as it did with this adolescent who was 13-year-old, and the mother was absolutely aghast. And she said, look at this doctor, we come from such an orthodox family, he has punctured his ears in multiple area, and now he wants to actually pierce the other ear. What should I do? So very coolly, keep calm and then answer is the rule in adolescent medicine. I told her, please refer him to a place which really follows sterile injection techniques for piercing. She was totally shocked. She said, and what do I tell him? I said, just ignore the piercing. And though she did not agree with me at that particular time, thankfully she followed my advice, and the adolescent had all the earrings out from both the ears within the next few weeks. We must understand that adolescents undergo an identity crisis. And in this case, it was a physical identity crisis. And when the adolescent got bored with this experimentation with the appearance, he just took them off. But in case the mother had reacted, it would have created a war at home. We all understand about head psychosocial history. Its importance is not only in picking up what Vijay said, the strengths, weaknesses, but also comorbidity and risk and protective factors. Because we know that The individual, himself or herself, the school, the peers, the family, community, the government, the governmental policy, and media all affect adolescent health and well-being. Let me explain this with an example. An adolescent with learning disability and attention deficit hyperactivities disorder goes to a school where he's abused by the teachers. He meets a gang of friends who drink and smoke, and so does his father. The community does not have any facility for remedial education or adolescent-friendly health services, and the community also encourages the use of alcohol, and so does the media. When this adolescent becomes an adult, he lands up in jail after robbing a bank, and he had dropped out of school just at the age of 15 years. So you can understand this collection of all risk factors have actually pushed this adolescent into risky behavior. Yes, research has proved again and again that parental and school connectedness, religiosity, and spirituality are the strongest protective factors and have to be encouraged by all pediatricians. Another girl which was brought by her father, and he said that my 16-year-old daughter has frequent headache and has become aggressive. Since 3 months, there has been a fall in academic performance. There have been fights and generalized aches and pains. So what do you think? Is it just normal adolescent behavior, or is it the onset of a mental disorder? Look at these points. Whenever there is aggressive behavior which is out of proportion to the development, and it has been lasting for more than 2 weeks with affecting the functioning of the adolescent, definitely is a flag sign of mental disorder. But look what happened. When I talked to this adolescent in privacy and confidentiality, when I talked about the home, she said, my mother has mood swings, she has rage attacks, and they were all pointers towards bipolar disorder. When the mother was referred to the psychiatrist under treatment, she felt better, the family felt better, and the aggression of the 16-year-old simply disappeared. So as a pediatrician, have your antenna up to pick up mental disorder, marital disharmony in the parents, and refer them accordingly. Another child of trichotillomania, a 14-year-old, and the father said, look at him, what is he doing? After I talked to the child, again another case of attention deficit hyperactivity disorder with learning disability. The father was an IATN and was forcing him to actually go for IIT coaching, which the child hated. He loved football and he was missing his football coaching. The father was a very authoritarian father. Actually, I partnered with the mother and tried to convince the father after 6 months of football coaching and parental coaching and remedial education. Look at the crop of hair. This is not the picture of my patient because he refused to get photographed. This is a picture picked up from the internet, which really looks just like what my patient did. So remember, partnering with the parents actually reaps rich dividends. Coming to the next practice pearl, rule out organic disorders. As a pediatrician, remember, anemia can mimic any mental health disorder. So if you can't do anything much, please treat anemia. 40% of our adolescent girls are anemic and 18% of the adolescent boys are anemic. And yes, needless to say, in mood swings, rule out hypothyroidism. This 11-year-old girl presented to the clinic with irritability and severe headache for 1 week. When I did a general physical examination, I found that there was conjunctival suffusion and there was a squint. So I referred her to the ophthalmologist, who laughed at me and said, oh, this is just corneal drying. Put her on some lubricant drops. And after 2 days, she came back with severe headache. And I felt the squint had worsened. So I changed the ophthalmologist. And in fact, I rang up the previous ophthalmologist and told him, and he joked with me and said, Preeti, you are missing a psychosomatic disorder. I was sure about my heads. It was not a psychosomatic disorder. It was not a somatoform disorder. The second ophthalmologist did an MRI and it turned out to be medial rectus cysticercosis. So be good with your clinical examination, be good with your clinical history taking. Please remember, all headaches are not indicative of somatoform disorders. The next practice pearl is you must rule out associated medical disorders like diabetes mellitus may be associated with depression. Important to manage both the physical and the mental disorder properly to really get good clinical results. ADHD, autism, learning disability, these all disorders should have been picked up much more earlier in childhood. And yes, they can be associated with comorbidities like depression, anxiety, even eating disorders and suicidal behavior. Also, remember that some disorders like urinary tract infection, especially recurrent urinary tract infection, may be a flag sign of sexual abuse. Recurrent vaginal discharge may be a flag sign of sexual abuse. Have your antenna up because you know that reporting of these cases is mandatory according to the law. Please brush up your mental status examination, brush up the technique of looking for orientation, appearance, thought, judgment, speech, perception. Please brush them up because we know that any problem in thoughts is probably indicative of psychosis and the child has to be referred to a mental health professional immediately. Useful to have screening tools in your private practice. These screening tools could include Beck's Depression Inventory and Patient Health Questionnaire 9 for depression, screening for childhood anxiety-related emotional disorders, the SCARE tool for anxiety, screening to behavior intervention, and CRAFT tool for screening for substance use disorder, Ask for questionnaire for screening for suicidal ideation. And remember, all these are screening tools to just indicate towards a diagnosis and to follow up the patient and check the response to counseling and clinical intervention. Actually, these tools have to be later. The findings have to be diagnosed. The gold standard is DSM-5. So according to the diagnosis, you will plan the pharmacotherapy and also the psychotherapy, and referral indications definitely need to be kept in mind. This is another example of a screening tool which has just 2 questions. Please have a look at this. It is called the Patient Health Questionnaire 2, and it has a great sensitivity and specificity for detecting major depression in adolescents. I would recommend all of you to read this article, which is freely available on the internet. It will give you a lot of information about heads and also about Patient Health Questionnaire 2. And another tool I would discuss in a moment. This mother got her 18-year-old son who was preparing for IIT in shock because she had detected this. And what is this? Marijuana in his bag. And she was absolutely shocked with this. And when I talked to this young man, he said that, yes, he was under a lot of stress and under the influence of his peers. To really combat this stress, he had taken marijuana just twice or thrice in the last 6 months. Now, there is an excellent tool which is called Screening to Brief Intervention tool, which has just 1 question. In the past 1 year, how many times have you used tobacco, alcohol, marijuana? Stop if it is never, otherwise you have to continue and ask for other hard drugs. Now, if the adolescent says never, how will you clinically interpret it? If the adolescent says never, it means no substance use. The adolescent here said, I have used it only 2 or 3 times. It means there is no substance use disorder, but yes, there is substance use. If the adolescent says that I have been using it monthly, it means there is mild to moderate substance use disorder. And if the adolescent says, I have been using drugs every week or more often, it means severe substance use disorder, and you have to refer this case. Luckily for us, 95% of the adolescents who use substances are following in these three categories. So what did I do for this adolescent? I told this adolescent, I can understand your need and your desire to join the IIT. Do you know marijuana has a direct effect on your hippocampus and prefrontal cortex, which will affect both your judgment and memory. And at this time, you want your brain efficiency to be topmost. I further said, for your stress management, I have this stress management pamphlet. And this was the brief advice which I gave him in just 5 minutes. And I said, I'll be happy to see you again in the adolescent clinic in the next few days. So this is what a practitioner can easily do in his clinical practice. And this young man did not get into IIT, but he got admission into RV College, which is an equally good college in Bangalore. Now the last case. I came back from my clinic one day and I got a phone call and the voice on the other end said, "Doctor, I'm standing at the edge of my balcony and I'm going to jump." I must tell you a little bit more about this case. Actually, this young girl had come to me a few days ago. And by the way, this is an imminent risk of suicide and you have to do an immediate referral to the mental health professional. As a practitioner, what do you do on the phone? Can you refer this child to the psychiatrist then? I'll come back to that again in a minute. So she had come to me a few days ago, brought by her mother. The mother said she had been on antidepressants for the last 1 year, but her aggression continues. The doctor feels that her psychiatrist feels she does not need any more antidepressants. Doctor, I want you to help her. What she needs is behavior therapy. Even the psychologist has given up on her. I talked to this young girl and I understood that there was a lot of sibling rivalry. I called her for another appointment the next day, but she refused to come. And that is the time, after a few days of that, I got this call from her. And I told her on the phone what happened. She said, "Doctor, you know how my mother is. Today I was talking to the next door neighboring boy. And when I came back home, she said, I am a prostitute." Come on, doctor, if your mother says that you are a prostitute, do you think life is worth living? Remember, she had 3 suicide attempts before, and she was hospitalized for all these 3 suicide attempts with a history of prolonged depression. Then I told her, if you have a 100-rupee note in your hand, and if you crush it, what is the value of the note? She said 100. And I said, so what do you think now? And she was intelligent. So she said, so do you think I should talk to my mother just now? I said, please do. If your mother thinks you are a prostitute, that doesn't make you one. You know what you are. So she said, my mother is in the bedroom. Should I go there? I heaved a sigh of relief. All I wanted her was to go away from the balcony to the bedroom. So she gave the phone to her mother, and I just told the mother, don't leave your child alone for today. Just talk with her and listen to her. Don't speak a word, just listen. And that set the pace of unconditional love, assertive communication, and counseling with the mother, not with the adolescent. I never saw the adolescent again, and I counseled this mother for nearly 1 year. This extended to telephonic counseling for 4 years. And now, just a few weeks ago, I got to know this adolescent is happily married, a chartered accountant, and planning to go abroad. So the last practice pearl, which I want to share with you, is counseling and partnership, and a toolkit for well-being of the adolescent, which can be used in all cases, really all cases. So we already know about this approach. What is actually counseling? Counseling is not telling the patient what to do. It is allowing the counselee to choose his decision and to help him to implement his decision according to his psychosocial, spiritual, and financial needs. Let me share with you this case of a 14-year-old brought by his sister, and the sister said, please help my brother. He goes to a red light area. And I talked to him in privacy with confidentiality and followed the approach. I listened to him. He said, I have nobody to talk with me. My parents are international lawyers. My sister is busy. I have nobody to talk with me. And that's the reason why I go to the red light area. So then we talked about the risks of the red light area. We talked about with whom could he talk? Could he talk with his other friends? Could he talk with his maid servants? Could he talk with his cousins, extended family? And he refused. He chose to go back to the red light area. I could again explain and review the key points. And what do you think I did next? I talked to him how to wear a condom the proper way. Remember, in adolescent medicine, if you can't do harm elimination, you have to work towards harm reduction. Keep the windows and doors of your clinic open. And yes, I asked him to come for follow-up because this child, in spite of wearing a condom, may still be prone to STI, and we need to really follow up this child very closely. So what is the stress management toolbox? Vijay has already alluded to it. Yes, talk to them about balanced exercise, eating healthy, sleeping for at least 8 to 9 hours, prayer, meditation, annual health checkups, immunization, problem solving, life skill, healthy media use in this time of COVID. Yes, stay away from physical distancing, but social closeness should increase. Use your study skills regularly, have a connect with nature, be grateful, help the grandparents at home, and yes, pursue your hobbies. What do you tell the parents? The toolkit is follow the authoritative style of parenting. Do as I do. Madam already told about role modeling. Stay away from authoritarian, uninvolved, or permissive parenting, or helicopter parenting, or snow plowing parenting, because this will make the adolescent very much dependent on you. What has COVID done? COVID has actually increased the mental health issues. In this survey, which we conducted in around 500 school students, 50% said, yes, they were affected by COVID. Another 50% said they were not. Out of that, 25% said that life was better. Most of the problems indicated a problem with being online, also an indication towards anxiety and depression, even online. Please remember that if you can develop a nurturing relationship with one trustworthy adult in their life, this is protected. And this is what the research says. What about me personally? The tele mental health services which I have been doing, I have done 74 teleconsultations in the last 6 months. And no surprises here, the maximum have been for increased media use and poor motivation to study. How do we prevent mental health problems? This is the key. The annual adolescent health visit. We must be up on it. We should know what to screen and what to do, both for physical health, mental health, psychosocial health, and emotional health. What is the role of pediatricians? The role of pediatrician is beyond the clinic. It is to go into the community, to take up school programs, to advocate even at the governmental level for adolescent mental health. Yes, there is the RKSK, the National Adolescent Health Strategy. If you get an opportunity to join this strategy, go for it. Implementation has been an issue in India. What is the framework for child and adolescent mental health services in LMICs? This is what we did from a recent paper. It is not only about doctors, it is about peer educators, teachers, community health workers, digital mental health services. Yes, on the top are child and adolescent mental health professionals. Seize the opportunity to make a difference, because if you wait too long, you will miss them. I wish all of you a very fulfilling adolescent clinical practice. And yes, you can.
Thank you so much, Dr. Preeti. It was a wonderful, excellent, exhaustive, and extensive session on the mental health issues by Dr. Vijayarani and Dr. Preeti. So nicely, aptly, and so wonderfully dealt with all the aspects. So nice.
Thank you.
There are no questions. We'll go to the next session. This will be the topic will be lifestyle in adolescence. A very important topic. This will be dealt by the expert, Dr. Newton Lewis. He is from Kerala. He's a wonderful, very practical adolescent physician, and he has published a book on child care in Malayalam in 2019. Over 200 classes on adolescents from 1999 onwards for adolescents, parents, teachers, and doctors. He has authored chapters in postgraduate textbook of pediatrics and Swati Bhave's madam's textbook on adolescents. He is the former secretary, state secretary of adolescent chapter, NNF and computer group, former treasurer, secretary, president of IAP Thrissur district, and he's in 2000 he's a winner of the IAP practicing pediatricians quiz. So he's an all-rounder, and he'll be the expert today, and the speaker will be none other than Dr. Lakshmi Shanti from Coimbatore, a wonderful pediatrician and an adolescent specialist. She is working in the Coimbatore Corporation Health Services and with a wonderful pediatric practice and special focus on adolescent health needs. Over to Dr. Lakshmi Shanti.
Good evening, friends. I thank the IAP TNSC office bearers for having me here. With both the outgoing president and the incoming president being adolescent torch bearers from Tamil Nadu, it gives me immense pleasure to be part of this program. So my topic will be on adolescent lifestyle. Just give me a moment to share my screen. So adolescent lifestyle is a very elaborate topic with so many determinants to it. So due to time constraints, I have focused on certain important things. Hope my screen is visible.
No, do you have any issues?
Is it visible now, sir?
It's not visible.
Now, sir?
No.
Actually, I'm able to see the screen.
No.
You have not shared, I think, Shanti. Huh? Share பண்ணலன்னு நினைக்கிறேன் Shanti.
இல்ல ஷேர் பண்ணிருக்கேன்.
Thirumurugan, you are here?
Yes, sir, I'm here.
Shanti slide வச்சிருக்கீங்களா?
செந்தில் சார் காமிச்சிருக்கேங்க சார்.
I'm downloading it.
Okay, okay.
Shanti,
இன்னொரு try பண்ணி பாருமா.
I'm doing it, sir.
Just exit பண்ணிட்டு திருப்பி share பண்ணு.
Okay, okay.
Stop screen sharing and then you try to come back, madam.
Is it visible now, sir?
No, Shanti. Send it to me. I'll share it.
Madam, can you just log out and log in back?
Sir, Newton sir, Newton sir, can you please share it?
Yeah, I'm just trying to put a. Can you see it?
Yeah.
Has it come?
Yeah, I'm able to see my slides, sir, but I don't know whether the.
Yes, sir.
Can you see it now?
Yes, sir. Now it has come. Yeah, it has come now.
So can I continue?
Yeah.
Yes, ma'am.
Okay, so my topic will be on adolescent lifestyle. It's a very elaborate topic.
Sorry.
So the objectives of my talk, I've structured my talk in such a way that I will discuss what comprises a healthy lifestyle in adolescence, the determinants of a healthy lifestyle with special focus on nutrition, sleep, and physical activity, some common problems that we see in pediatric practice with the adolescent patients, and the role of a primary care pediatrician in dealing with such patients.
Managing slides.
So what is lifestyle? The WHO defines lifestyle as an identifiable behavioral pattern determined by the interaction between individual personal characteristics, social interactions, socio-economic and environmental life conditions. But actually we needn't worry about this long definition, because as far as an adolescent is concerned, his lifestyle, the most important factor that determines his lifestyle is friends. So peer influence is a very important factor for an adolescent. So whatever his friends do, he follows the same. So we have to ensure that this influence from the peer group is in a positive way and not in a negative way. So we should just ensure, as pediatricians and parents, we should ensure that this healthy adolescent comprises of the following: a successful transition from child to adult, the skill development he needs to respond to the various changes that takes place during this period of adolescence, the various physical changes and mental changes, absence of physical or mental disease, and finally, development of a healthy lifestyle. That's what we are going to see now. Now, coming to the determinants of a healthy lifestyle, the first and foremost is the health responsibility, meaning the self-assertiveness or the self-awareness that an adolescent should have. And then we have nutrition, physical activity, positive life perspective, interpersonal relationships, stress management, and spiritual health. So I'll just focus on nutrition, sleep, and physical activity for want of time. So coming to nutrition, which is the key determinant or the most important factor of an adolescent's lifestyle. So we have, according to the food guidelines, all of us here, we know that our diet should comprise of 50 to 60% of carbs, 15% of proteins, and 20% of fats. Of these composition of the diet, this is the healthy eating plate which an adolescent should be following. And half of this plate should contain of the whole grains and protein from both the animal and non-animal sources. And the other half of the plate should contain vegetables and fruits, preferably fruits of all colors and veggies of all categories. So this is what the healthy eating plate should contain. On the top right, we can see the oil, the healthy oils. It's another important factor. We should avoid trans fat in the diet. The trans fat is what we see in all the pastries and all those processed foods that is available in various colors and shapes in all the supermarkets. So all these contain trans fat, which has to be avoided. And even in the home cooked food, sometimes the oil may be recycled, which may contain trans fat. And in the top left, we have the water. So coming to water, an adolescent will need around 2 to 3 liters of water per day. And most of these adolescents overlook the intake of water. Even if they feel thirsty, they tend not to drink much, so leaving them dehydrated all the time. So we have to concentrate on the water intake also. So coming to the recommended dietary allowance for the adolescents, the boys would require somewhere between 2000 to 3000 calories depending on the age group, and around 50 grams of protein per day. And the girls will need somewhere around 2000 to 2500 calories, again with 50 grams of protein. So both of them would need 800 milligrams of calcium, or roughly speaking, an adolescent boy would need the same amount of calories as that of an adult sedentary male, and an adolescent girl would need the amount of calories a little more than what her mother is taking. So these are the ICMR guidelines that have been taken from Dr. Swati Bhave's ma'am textbook of adolescent medicine. And also important is iron intake for adolescent, which varies between 30 to 40 milligrams per day. And other micronutrients are also very important. And now coming to the don'ts. So we saw what an adolescent should be taking. Now we come to what an adolescent shouldn't be taking. So we all know these adolescents are into junk food intake. So to popularize this term junks was introduced by our past president, IAP president, Dr. Piyush Gupta sir. And there is an excellent article in the IAP journal, Pediatrics, where there are guidelines related to the junks consumption and the guidelines to be followed by the schools and the government. So according to this, the mnemonic, the J stands for junk foods, which foods high in fats, sugars, salts, at the same time lacking in micronutrients. So these foods, they contribute not only contribute to overweight and obesity, but also lead to micronutrient deficiency. So U stands for ultra processed foods, meaning the food goes through repeated cycles of process, which makes them calorie dense. So even a small amount of the ultra processed food may lead to fat deposition and obesity in the long run. N stands for nutritionally inappropriate foods, or foods that provide empty calories and of no nutritional value. The C stands for caffeinated, colored, carbonated beverages, which is a very popular thing among especially the adolescent boys. And these contain the caffeine content in these beverages a little more than what an adolescent should be having. This may lead to problems in the long run. And finally, sugar sweetened beverages. So we have all these fruit juices coming in colored cartons and packages. And these adolescents think that these fruit juices are very healthy, but it's otherwise. Actually, these, for example, a 200 ml carton of any fruit juice may contain about 20 to 30 grams of sugar, which is almost half the requirement of sugar for 1 day. So these adolescents, we should encourage them to have to be very proactive and look at the nutritional value or look at the labels of these foods and decide before making a choice. They should look at the labels and decide whether this is a healthy one. So the nutritional values of all the packed items should be displayed. What are the ill effects of junks consumption? So the first and the foremost is, we all know, it's overweight and obesity. The second will be the cardiometabolic risk. Research and studies have shown that the process of atherosclerosis or the fat deposition in the coronary artery begins as early in adolescence. So any teenager or adolescent should watch what he is eating, especially when it comes to the fats and oils. So this leads to an increase in the lipids, cholesterol level, and the decrease in the good cholesterol or the HDL levels. And also this junk food consumption leads to an increased risk of insulin resistance and even frank diabetes mellitus. Essential hypertension, especially due to the increased amount of salt in these processed foods. And we have seen that this junk food consumption leads to behavioral changes in these adolescents. And this has been attributed to the oxidative stress response and the inflammation associated with the harmful chemicals that are released during the processing of these junk foods. And other less important things like dental caries. Another one important thing that I wanted to highlight is these caffeinated drinks, they carry the risk of cardiotoxicity. It could range from a simple tachycardia or to even severe issues like arrhythmias and even sudden death. And we've even had newspaper reports of teens who are like binge watching or gaming with all their junk food and drinks and suddenly collapsing on the table. We have had 2 to 3 cases of death. All of these can be attributed to such harmful chemicals. So what are the common problems that a pediatrician encounters when it comes to nutrition in an adolescent? So the common thing that the parent tells or even the adolescent reveals during the head's interview is that he skips breakfast. So skipping breakfast and inadequate hydration are the two most important problems encountered. And this inadequate hydration can lead to like symptoms like easy fatigability. They also complain of giddiness. And when we check their pressures, it might be low. And later, if we probe into their water intake, it may be low. And just correction of this hydration and nutrition can solve these simple problems. And there are again deficiencies like anemia and micronutrient deficiencies giving to many problems. Especially in adolescent girls, anemia is a very important thing to watch out for, because these girls are future prospective mothers and they have to have their iron stores should be good. And this weekly iron folic acid supplementation done by the government is very helpful in preventing adolescent anemia. And then we have all the obesity and the lifestyle diseases. And for nutrition, when it comes to nutrition, teenage girls, as we already discussed from the first speaker, Dr. Sri Priya, about the body image disorders, they all present with these dietary fads. They're influenced by their friends and they follow like quick fix diets to lose weight and land up in eating disorders. At the same time, adults are engrossed in going for these energy drinks and protein shakes, influenced by these friends. And when coming to the protein shakes, I just wanted to highlight, I just had two adolescent boys coming to me at the age of 13, 14 with complaints of gynecomastia. So when probing further into their nutrition and the dietary pattern, like they admitted to taking these shakes, and we should also know that some of these protein shakes may contain steroids, and they may also contain minute amounts of phytoestrogens. So we as pediatricians should be aware of these things, and we should do this anticipatory guidance and ask them for their dietary pattern, because they are easily influenced by their friends. And if they're going to the gyms, they're influenced by the trainers to buy these protein shakes, which are very expensive. And in the long run, it can create many problems in their health. Next, coming to sleep. So I just wanted to focus on sleep as an important lifestyle issue, because it is I thought it's the most ignored part of a lifestyle. An adolescent needs about 8 to 10 hours of sleep per day. But there are certain changes taking place in the biological systems of an adolescent that result in a 2-hour delay in the sleep-wake cycle. For example, a child who used to sleep by 9 o'clock, 10 o'clock every day, when he reaches the adolescent age, the circadian rhythm is altered so that there is a 2-hour delay. So he may sleep by 11 or 12. But at the same time, he has to get up at the same time early morning to report to his school. Or as Preeti ma'am said, there are so many coaching centers, IAT, medical. He has to report to these coaching centers. In addition, he may have some extracurricular activities. So all these are taking a toll on his sleep. And this leads to a sleep debt and leading to a chronic sleep insufficiency. We as pediatricians should remember that sleep in adolescence supports learning, memory, attention, cognition, and emotion processing. So it's not enough if he goes to multiple coaching classes. He needs to have a proper duration and the quality of sleep. So this is one slide where I wanted to take some time, because this slide explains the whole behavior, the sleep behavior in a teen, and what are the outcomes of this deranged sleep physiology. So the first thing that tells about the modifiable extrinsic pressures, the first one is the school start times. So most of the schools start very early, especially for the higher secondary, that is the adolescent age group students, for want of academic thing. And in addition to this, they have extracurricular activities and also these coaching centers. And finally is the technology. So every adolescent, when he retires to his room for sleep, into his bed, he invariably carries a gadget with him, be it a mobile or a laptop or whatever. So there is a gadget that takes another 1 or 2 hours of his sleep time invariably. So whatever we advise, they tend to do this. So all these take a toll on his sleep duration. So these are all modifiable extrinsic pressures where we can play a role in preventing this problem. So coming to the sleep behavior, we, as already told, the circadian rhythms are altered. So the timing is a bit delayed. And coming to the sleep physiology, we have these slow waves and the sleep spindles. So there is a derangement between the slow waves and sleep spindles, which have an effect on the gray matter and the white matter maturation in the brain. So as we already saw of all the brain development slides, we know that the adolescent's prefrontal cortex is still maturing, and this altered sleep physiology has an effect on this maturation patterns in the adolescent brain. So what are the outcomes of this problem of this deranged sleep in a teenage? The first thing is the intellectual ability is reduced, learning and memory problems are there. All these leads to academic problems and a fall in grades. And another one is the emotional regulation. Because of these sleep derangements, they tend to have these aggressive behavior and anger issues, and sometimes hyperactivity, oppositional. There are so many behavioral issues that can be attributed to this deranged sleep physiology. And one more thing I wanted to highlight is the risk-taking and injury. Because they have a chronic sleep deprivation, they tend to have this daytime sleepiness. And if they're driving vehicles, so this sleep deprivation may lead to what is called the sleep cycles during the daytime. And especially when driving a vehicle, this can be very harmful, resulting in even serious accidents and injuries. So this shows that sleep, the duration and quality of sleep is a very important factor that determines the healthy lifestyle in an adolescent. So what can we do? What can we do as pediatricians and as parents? What can we do to ensure a proper sleep hygiene in an adolescent? So first thing is that they should maintain a regular sleep schedule on all days of the week, but it is a very difficult thing. So we can advise them. It is even difficult for us to follow. We tend to sleep late on weekends, but at least we have to try to keep the difference in the wake times to less than an hour. If suppose they want to sleep late on weekends, just keep the difference less than an hour. And then create a sleep-friendly physical environment, a cool, quiet, and dark room. And the bed should be used only for sleeping, not for any other activities like homework or working on projects, etc. And next, incorporate exercise into the daily routine, because this releases the feel-good hormones and gives them a good night's sleep. And they should take a break and go outside and get some bright sunlight once in a while. This helps.
Slide is moving. Slides are moving.
Yes, sir. It's moving, sir.
Am I audible, sir?
Yeah. Please continue.
Okay, so they should get some that sunlight for that vitamin D, and also to keep the body's internal clock on track. And regular meals, avoid going to bed on an empty stomach, and limit screens or gadgets in the bedroom. And another important thing is avoid caffeinated drinks, heavy meals, and also heavy workout before bedtime. And they should try to have 1 hour screen-free time before going to bed. So we have to ensure that all these are followed for a healthy sleep hygiene. So next, coming to physical activity, which is a very important part of an adolescent lifestyle. So we as pediatricians, when we see overweight, obese patients, we advise them to do physical activity. But I thought we should have some knowledge, basic knowledge about physical activity, so that we should advise them in a better way. So physical activity, it has both the exercise that can be done in a gym or at home, which is a planned, structured physical activity, and also non-exercise activities that includes the day-to-day activities. As Vijayarani ma'am told, many adolescents say that I work out in the gym for an hour, but at home they are literally couch potatoes. So they also have to do the day-to-day activities and keep them active. So the WHO recommendations of physical activity applies to all children aged 6 to 17 years. So which says they should do 60 minutes or more of physical activity daily. And most of this activity should be either moderate or vigorous intensity aerobic physical activity. And as part of this 60-minute activity, they should also include muscle strengthening and bone strengthening activities on at least 3 days of the week. I'll come to it in the next slides. So coming to the types of physical activity, the first one is the aerobic, which we saw, the activities that are intense and involve the large muscle groups. For example, walking, running, basketball, dancing, all kinds of sports activities. And I just wanted to highlight a little on this anaerobic physical activity, which means high intensity activity that exceeds the capacity of the cardiovascular system to provide oxygen, meaning it involves the non-oxygen pathways, and it involves sprinting, powerlifting, example for anaerobic. And this is very important because it builds the lean muscle, and this anaerobic physical activity leads to a fat burn or calorie burn for up to 48 hours post workout, so that the workout that is done on the next day has a better calorie burn. So this anaerobic physical activity should be incorporated at least on 2 to 3 days of a week for better results, especially for obese and overweight children. And then muscle strengthening physical activity doesn't necessarily mean lifting weights in a gym or doing very severe activities. It could also include daily activities like carrying heavy bags, climbing stairs. Climbing stairs is a very interesting and a good exercise that improves the endurance in an adolescent. And especially the last year when we are all confined to our homes and we couldn't go to gyms or do walking or running. So this climbing stairs could be done very easily inside the confines of a home, and it's a very good exercise for endurance and also for strengthening the muscles. Bone strengthening, movements that create impact and muscle loading forces on the brain, for example, jumping, hopping, and things, skipping, etc. And there are some less important things like balance training and flexibility training, which is more important for adolescents who are engaged in sports related activity. And another important thing I wanted to highlight is yoga and Tai Chi. These are two amazing exercises that combine muscle strengthening, balance training, light intensity aerobic activity, and flexibility all in one package. So it can also be called the mind body activities, as they relax the mind too. So it's high time that we as Indians, so we invented the yoga. So the Western are aping us and doing yoga. So we should do it. Like, we should encourage our adolescents to follow this yoga at least once in a week, so that it relaxes the mind. So the Physical Activity Guidelines Advisory Committee report of 2018 has documented the following conclusions, which is on a very positive note, especially for the adolescent age group. These are the following conclusions. The higher amount of physical activity has shown the following advantages: an increased cardiorespiratory fitness, increased muscular fitness, thereby decreasing the fat, increased bone mass and improved bone structure and strength, thereby decreasing the risk of fractures, a better lipid profile, and decreased risk of obesity and lifestyle diseases. So having said so much about physical activity, last year 2020 was such a year that we were all driven by this pandemic, and we were all confined to our homes and inside four walls. Our children were into e-learning and we were into webinars. So we were all confined to our screens. So we were advising the children to limit screen time, but we couldn't do that. But we had to learn to adapt to this new normal, that is the screen time. So I just added 2 slides on what is called the ergonomics, which is the interaction between human activity and the components of this activity. Because we are glued to our screens, our children are into the online classes for about 4 to 6 hours a day. And I thought I would add some tips for them to be healthy in spite of these continuous screen time. So this 20-20-20 rule, which is taking a 20-second break every 20 minutes and looking 20 feet away from the screen. This has to be followed by the children and the adolescents. And during these breaks, they can do some simple stretches like side bends, shoulder shrugs, finger, wrist and thumb stretch, etc. And while they are seated for the class, we should ensure that the monitor, the top of the monitor should be in the eye level, and the face should be straight ahead, and the head shouldn't be slumped forward. And the sitting should be proper with the height of the chair, if possible, adjustable. Eye strain should be avoided by reducing lighting in the room and also reducing the screen brightness and taking breaks in between. And if possible, a footrest can be had with keeping the feet flat on the floor. So we are again poised for like online classes for another 6 months or so, because just now the vaccine rollout has begun. So we cannot expect the schools to open in the immediate future. So these are some tips that we can, as pediatricians and parents, ensure that our children follow these. And coming to the other determinants of lifestyle, I just tell a few points due to want of time. The first one, as I said, it's the health responsibility. Every adolescent should be self-motivated to follow a healthy lifestyle and be responsible for his or her health. And then positive life perspective, an optimistic attitude is needed for a teenager to cross over the various challenges and hurdles that he faces. And next, coming to the interpersonal relationships, this is one important thing that we have to be aware of, because our teenagers, they have a very good IQs, their intelligent quotients are very high, they enter prestigious colleges and land up in very plum jobs, but they lack in what is called the emotional quotient and the empathy. This is the key to holding successful relationships, but unfortunately they land up they fail in relationships, leading to divorces and things like that. So we should focus on this interpersonal relationships. And stress management, this is a topic by itself, so I'm not going into much. And finally, spiritual health. Spiritual health doesn't necessarily mean visiting a temple or worshipping. It relates to the connection with self, with others, with nature, and with the supreme power. So teenagers who develop mindfulness practices, mindfulness as told by Dr. Preeti ma'am, these adolescents, they have better resilience and score well in the mental health issues. So coming finally to take home points, what can a pediatrician do when it comes to an adolescent lifestyle? A proper HEADS interview covers all the lifestyle issues faced by an adolescent, and anticipatory guidance is what we need to do while doing the HEADS interview, which helps them lead a healthy lifestyle. And again, counseling parents is another important factor. And when it comes to an adolescent clinic, we can display some posters or flyers pertaining to nutrition, physical activity, preventing obesity, etc. So this should be the prime responsibility of an adolescent physician and a pediatrician. Thank you. Thank you for the opportunity for all the office bearers of IAP. And also I would like to thank Dr. Newton sir for giving me valuable inputs in doing this presentation. Thank you, sir. Over to Dr. Newton, sir.
Dr. Newton, sir, please proceed.
Yes, sir. I'm sorry. I'm trying to. Hello, can you see me? Have I succeeded in sharing the screen?
No.
No. I'll try it again. Yeah. Sorry.
Yeah.
Yes, sir.
Yeah. Yeah. Can you see me?
Yeah.
Yes.
Okay, fine. So after a very comprehensive talk, I think my work is over. I don't have to mention anything about the life skill, about all these details about sedentary lifestyle, sleep deprivation. She has covered everything, including nutrition, very in depth. I will just add a few extra points. Now, basically, when we talk about lifestyle disease, we focus on obesity, diabetes, hypertension, high cholesterol, these problems which are becoming a big issue for the next generation. The others also are lifestyle diseases, but we will not be discussing now for lack of time. Now, why is there so much of talk about obesity, diabetes, hypertension? Look at these latest statistics from the Comprehensive National Nutrition Survey 2019 of the Government of India. For Tamil Nadu, it shows that 70% have obesity or overweight. There's around 10% are at risk for diabetes, high HbA1c. There's a lot of low HDL and LDL, all the Tamil Nadu statistics, and a small amount of chance of hypertension too. So the risk factors in our adolescents is very much there. And why so many risk factors? Why are we having so much of problems? Well, you look at these Indian statistics, which shows that the adolescent in the last 1 week, 60% of them had zero consumption of fruits, and 25% had zero consumption even of vegetables. With this kind of a irregular food pattern, how much of health can you expect? Why don't adolescents eat properly? Because adolescents are adolescents. They love to experiment with different foods, and there's a lot that they can experiment with in the present condition. New foods that they don't get at home. Their desire for independence and for independence from the type of food that is served regularly at home. Peer influence, a big issue. Advertisements, which easily convince adolescents. And of course, their immediate need for taste and convenience, and the inability to think long term about the health consequences of the type of food they're eating. So, sorry. Yeah. So how do we advise them about good nutrition? There's no point telling the adolescent, okay, in 30 years time, 40 years time, you're going to get a young, early heart attack at the age of 40 years or 50 years. They don't have the ability to think that long. They're not mature enough. And we were just talking about before 25, their prefrontal cortex is not mature enough. So what we can tell them is about what they are interested, that if you have good nutrition, you're not anemic, you have a balanced diet, you look good, you're slim, you look good, good complexion, you are more efficient in your studies and perform much better in sports. That is how you have to inspire them. And what advice can we give these children who have these who are prone to this type of problems? Well, giving them complex advice is not going to help because they don't have the patience or the ability to understand them. It's better to use a traffic light signal. Green is for fruits and vegetables. Eat unlimited quantities of them. The more you eat, the better. The greater variety of fruits and vegetables you eat, the better. Yellow is for the foods that you have to limit. Eat, but within limits. Grains, dairy, fish, chicken, and lean meat. Meat from which all the visible fat has been removed. Here, with regard to grains, we adults too, we are so used to filling up the plate with rice or with so many chapatis before we put some curries. You go for a grand wedding and there's some 50 curries and we still fill up a plate with rice and then we just have little place for the curries. Wouldn't it be better to just take a handful of rice and fill up the plate with all those lovely curries? We don't get a chance to taste half the vegetables and non-veg curries that are there because we filled up our plate with rice. Grains have to be cut down. They're just a bad habit. And of course, red. Totally try to avoid as much as possible oily food, sugar, sweetened beverages which contain high percentages of sugars. And even though they are called fruit juices, they are predominantly sugar, and all fatty meals. And with regard to good feeding and eating practices, remember that for the adolescent and for all persons, meal time should be family time. No mobiles, no TV, all sit together and eat. Now, if you're doing that, not only the family atmosphere improves, but also you're all talking to each other, eating slowly, and your appetite center has the time to tell you, okay, yes, I'm feeling full. Now you can stop eating. You don't just keep on eating fast without realizing how much you're taking. And if an adolescent is obese or has acanthosis nigricans, giving him advice is of no use. The whole family diet has to improve. We can't eat pizza and tell him to eat only, lots of fruits and vegetables. We have to improve the whole family diet. Drinking water is a very good habit. Before meals, during meals, after meals. This strange belief that water interferes with digestion is totally unscientific. It fills up your stomach and thereby helps you to eat less. Eat from a smaller plate. It sounds so obvious, but it is a fact that if you take from a flat and a small plate, you fill it up, you are going to eat much. You're going to feel that, oh, my plate is full, but actually there's a much smaller quantity. Now, you know the plate is smaller. You know, therefore, that there must be less food on it, but still it gives the mind satisfaction that I'm eating a full plate. So just eating from a smaller plate rather than a bowl or a large plate helps us in dieting. It's a simple trick. Avoid watching TV while eating. Well, I hardly watch TV, but once while I was watching TV, something exciting on AXN, In half an hour's time, there was some halwa there, black halwa, and I was just pinching away at it. In half an hour's time, the program was over and the halwa was over, quarter kilo. So never watch TV while eating. You are not looking at what you're eating. You're not thinking about what you're eating. You're just pushing it down your throat. Avoid eating while watching TV. Eating is only at mealtime. While watching TV, you're snacking. You're not eating. No eating in the bedroom. No eating while sitting on the watching TV. Eat only at the dinner time. Only at meals. And eat breakfast. It's a common practice in the West, very common, and now it's becoming very common in our country too, for adolescents and adults to say that they are dieting. How? By not eating breakfast. I'm avoiding one total meal. It has been proved in umpteen studies that if you avoid breakfast for 6 months, you will gain at least 2 or 3 kilos, because the body cannot tolerate the starvation, overnight starvation, and again you're missing breakfast. Your body rebels. You are trying your best to control, but you're not aware of it. At lunchtime, you accidentally put a little more in your plate. At dinner time, you accidentally eat a little more. And if you're passing by and there's some small little snack, there are just a cup of tea or just some vada, and it just goes into your mouth and you're not even aware of it. You're not thinking about it, but accidentally we overcompensate if we miss breakfast. Right. That's all I have to say very briefly about obesity. Now, this advice applies to an adolescent when you're talking about reducing obesity or preventing diabetes, hypertension, high cholesterol. Basically, the principles are the same everywhere. There's no need to go into finicky detail about each thing. The only extra point maybe is in hypertension. We will also talk about reducing. So, even in a person who's prone to hypertension, we'll talk about the recommendation to take less than 6 grams of salt. Other than that, the same principles apply in all situations. Now, the Baca hypothesis, which I was specifically asked to mention. Now, what is the Baca hypothesis? That if a child is born 2.2 kilos instead of 3 kilos, is an IUGR, in the future, 50 years from now, he has a much higher chance of developing obesity, diabetes, hypertension, high cholesterol, all the problems, if the undernourished child compared to the normally developed, the normal child, the 2.2 kilo baby rather than the 3 kilo baby. That is why this generation is facing such an explosive increase in all these conditions, because especially in the past, there was a lot of IUGR in our society. Today, that is hopefully very slowly decreasing. But all those IUGRs had a significantly higher risk of these diseases. Even those who are well-nourished can have this, but it is much higher in these people. So, going back, when we talk of all these coronary artery risk, we are talking about a child or adult who consumes too much calories, sugar, salt, fats. We talk about that. We should be talking about that. But let's remember that that is a secondary cause. Behind that, a lot of the problem was caused long before it was caused by the person. Even while in the fetus, he received too few calories, and that was where the problem actually started. And why did this happen? Because even today, there are no exact statistics, but around 20% of first-time mothers who are around 18 or 20 years of age, most of them, are less than 145 centimeters or less than 45 kilos, which means they are highly prone to have IUGR babies. And this is the Baca hypothesis. If you are this is a very simplified explanation, but it's accurate. If you are IUGR, you're going to be small, the baby, and that small baby will obviously have a small pancreas, a small kidney, and a small muscle mass. And if you have a small pancreas, that means a less number of pancreatic cells. And even when he grows, the number of cells will increase only up to a limit. After that, it's a increase in number. Hyperplasia has its limitations. Later, it's going to be hypertrophy and deposition of fat. So these persons, permanently, they have a reduction in the number of pancreatic cells. And after 10 or 50 years, why? They have a higher chance of developing diabetes. And a smaller kidney means lesser number of nephrons and later hypertension. Smaller muscle mass, one of the functions of the muscle is to absorb all that glucose that comes into your blood when you eat. Absorb that blood, store it as glycogen, reduce the blood levels. And that's not happening because the muscle mass is less, there's less storage. And in fact, there is some amount of insulin resistance also, so the muscle mass does not absorb as much as it should theoretically absorb. Why? because the fetus wants the blood sugar to remain high, because even if the muscle suffers, even if the other organs suffer, at least there must be adequately high levels of blood glucose to protect the brain and the heart. So that insulin resistance to protect the brain and the heart is going to cause damage 50 years down the line. IUGR is basically chronic undernutrition, chronic mild starvation, which means it's a stress situation, which means that cortisol and catecholamines are high, and you're going to get high levels of sugar, blood pressure, and cholesterol, starting from the fetal life. There are also some mechanisms which are not clearly understood, like, for example, the arterial structure itself is modified so that you get atherosclerosis. The liver is damaged so that there is more of dyslipidemia and more of clotting problems. Other tissues are affected in more complex ways which are still not clearly understood. This, what I've shown in this slide, are proven cases, methods. So, okay, we know the Barker hypothesis. The child was born 2 kilos rather than 3 kilos is more likely to have these problems. Now, there has been a suggestion in India, not abroad, in India alone, repeatedly in many conferences that, okay, one way we can avoid this problem is they are born small. If we keep them small throughout infancy, they will in the future have less of obesity, diabetes, hypertension, cholesterol. So let them starve. Let them remain chronically understarved, not only at birth, but also for the next 1-2 years. Then they will not have problems. Nice theory and possibly effective. Possibly they will not have, they'll become skinny adults and they won't have much of obesity, but very dangerous. After birth, the child is born with 35 centimeters head circumference, which is a proxy for the size of the brain, 35 centimeters. At 1 year, he is 47 centimeters. At adulthood, he is 55, which means that in the first year of life, head circumference increases 12 centimeters. And for the rest of your life, head circumference is only going to increase 8 centimeters. If you reduce the growth of the child for the first 1 year, if you do not give aggressive nutrition for the first 1 year, you're reducing permanently the number of brain cells and the size of the brain. And do you think it's worth it? What is more important? Are you going to sacrifice the intelligence of the child so that he will not have cholesterol after 50 years? I think that's a very bad choice. Similarly with height, and why is this important? Remember that from the fetus grows at their most rapid velocity possible. The next period of rapid velocity is in infancy, from 3 kilos to 10 kilos in 1 year, 300% increase. And the next year, from 10 to 12 kilos, only 20% increase. What I'm trying to say is that infancy is a continuation of fetal life. Infancy is a slowing but continuation of fetal growth. It is also a period of rapid growth, of rapid hyperplasia of all body tissues. And during this time, the brain is growing, the kidneys are growing, the muscles are growing, the kidneys are growing, all tissues, the pancreas is growing, all the tissues are growing. Hyperplasia more than just hypertrophy. So this is protective. In fact, it has now been proved, repeated studies, that those who are IUGR and the IUGR was corrected by 1 year of life, their chance of developing all the problems of the metabolic syndrome are dramatically decreased. Not 100%, but maybe 60-70%. The worst prognosis for those who are born small and continue to remain small at 1 year of life. They have the worst prognosis. Those who were born small and by 1 year the undernutrition was corrected to a great extent, their chance of developing all these diseases is much less. These were proved for the first time by Barker. And here I've given you one reference also, one easy and good reference. There are plenty of references to this, review articles on this on the internet. I've just chosen a recent reference, which is very easy to understand. Right, my talk is over. But before we end talking all about adolescents, just think about ourselves. The last 1 year, COVID-19, and it's been miserable for the whole world, miserable for all of us. And we pediatrics have had not much of work to do, but possibly there were some hidden benefits. Many of us found that we had plenty of time on our hands, and I started doing 1 hour of vigorous exercise. Like Lakshmi Shanti said, yoga, half an hour of yoga and half an hour of treadmill, and it's helped me a lot. All my parameters have improved a lot. Senthil was saying exactly the same thing. In the last 1 year, he's been exercising beautifully and he's very happy with the results. Many of us have done this. Now, COVID is not gone. Another thing that we had is that we had plenty of time on our hands. So we had plenty of time for our spouses, plenty of times for our children, time that we did not have earlier. I had 7 months with my grandchild, which was a very unusual and great experience. Now, COVID is not gone. COVID will be there with us, and all the rules of COVID and the social distancing and masks and all that will be there with us for 1 more year. We've got 1 more year to take advantage of this instead of always working, and we physicians have no time for exercise. This year, let us start exercising. Let us benefit to some extent from COVID. Thank you. Sir?
Thank you,
Senthil, you are
Dr.
there?
Newton, for your excellent.
Senthil?
Go ahead, Ismail. Yeah, it was a wonderful session by Dr. Lakshmi Shanti and Dr. Newton. So nicely dealt with and very detailed. So there were common topics and basic topics. They were dealt very beautifully, and I really appreciate their what they have taken so much of efforts to prepare these lectures. And one thing I would like to say is that but it will be most likely released in Puduvai, and it's a wonderful guide for the parents. We are trying to translate it in Tamil, and we are going to bring it out in Puduvai Pedicon. This is for your information. He has brought such a wonderful book, and very practical, very crisp, and very clear suggestions to the parents. So this is how I would like to appreciate his contributions to IAP and to the society. So, and Dr. Lakshmi Shanti was wonderful in her presentation. And next, I think Dr. Vijayarani will take over.
Dr. Vijayarani, unmute.
Yeah, the next topic is by, 1 second, please, sorry. Okay. The next topic is by Dr. Akila Ayavu, Pediatrician's Perspective, Diagnosis and Management of PCOS. So just like the others, star speakers, Dr. Akila, she needs no introduction. She's a star in Coimbatore. Actually, I'm sorry, I had made some mistakes in the past by not recognizing her and, lost track of it. So she is trained in medicine, pediatrics, fellowship in pediatric endocrinology, DIPENB, and PhD in medicine, pediatric endocrinology. She has many publications to her credit, and her current projects like development outcomes in children diagnosed early versus late with congenital hypothyroidism, and many more to come. She has authored chapters in textbooks on pediatric endocrinology, and she's presented a lot of papers, and which will take a lot of time to really tell it out here. So over to Dr. Akila. We are all very enthusiastically waiting for your talk.
Dr. Vijayarani, overall a wonderful human being.
Everybody has spoken about what all I had to speak. So I'm just wondering, what do I speak now? It was such a wonderful session. Dr. Newton finished off most of what I had to do on Barker's hypothesis. Dr. Vijayarani also alluded to it. Then Lakshmi Shanti finished off all the exercise part. Then there was one part by Dr. Newton on diet. So what do I speak about? I actually have nothing to add. I can say one hi and bye and just say it's been wonderful to see all of you here. I probably have 4 slides, which all of them have not talked about. That's all I have left. So PCOS, how can pediatricians help? I think it's actually, I'm going to talk to the audience who are general pediatricians, and that's what Ismail wanted me to concentrate on. Because this faculty of speakers know everything that is already there. So I don't think I have anything much to add to all of what all you know. So this is Ismail's heading to my topic. Hello, கொஞ்சம் புரியுற மாதிரி சொன்னா கேட்போம்ல. நிறைய சொல்லிட்டாங்க. நான் என்ன சொல்ல போறேன்ப்பா? எல்லாரும் சொல்லிட்டாங்க, நிறைய சொல்லிட்டாங்க, ரொம்ப சொல்லிட்டாங்க. நான் சுருக்கமா வரைஞ்சு பார்க்கிறேன்.
Yes.
Okay. So I actually asked a group of our pediatricians on what do they know about PCOS. So they said they know about hirsutism, irregular periods. Then they said acne, obesity, metabolic syndrome, and elevated testosterone. And they also seem to know about everything. Then they said you can see polycystic ovaries on ultrasound. And then psychologically, they said the adolescents are upset about that. And as such, adolescents are an upset group. And then in pediatric endocrinology, the group I'm really worried about is children, adolescents having diabetes. That's the really difficult team that you have to speak to. So I would say weight loss has an important role in PCOS, and that's what the pediatricians told me. And then they said diet and exercise plays an important role in management of PCOS. Metformin could be used for insulin resistance. OCPs are used for irregular periods, and fertility issues are a problem in adulthood. So why should we know about this? Could we have done something to prevent this? What could we have done? And when should we have done this? Or should we have referred early and to whom? So what are the long-term risks of PCOS? All of us know about that elevated male hormones in girls, menstrual irregularities, but you should also remember that all, just a minute. You should also know that all girls have, you should remember Artha Narishwara. So you are a part male and you're a part female, which actually exists in everyone. It's also a part in girls where you have male and female hormones. So you have to know when the proportion becomes a little bit different. It's not huge, it's only a slight difference, and then it carries on into a number of risks for both short term and long term. And then you also remember about reproductive morbidity and infertility. So in India, it is important to have children. Though I'm seeing a shift in the paradigm, a lot of young girls now don't want to have children, even if they're married and if they can have children. So it's actually becoming easier, and families are also having much more realistic expectations now and are willing to listen to what could be done for them. And then type 2 diabetes mellitus, and then insulin resistance, hypertension, dyslipidemia. I think everybody has spoken about it. I'm not going to talk about it. So modifiable risk factor, unmodifiable risk factor. நமக்குன்னு எழுதி வச்ச சொத்து நம்மளா சேர்க்கிற சொத்து. So I will say what you are inheriting from your family. Sometimes you get 0, sometimes you get lots. When you get 0, you're happier when you have a history of PCOS in the family. But when you inherit a risk for PCOS, so you should remember you can actually inherit a risk for PCOS from your mom. So it should be a unmodifiable risk factor. So you cannot alter that, but you can alter what you can do. Dr. Newton was talking about how children born small for gestation age should not be allowed to feed too much. And then he said it compromises growth. But when you are on a regular follow-up, you should not push food into the child. Children with catch-up weight, trying to catch up on weight, please monitor the length and the height that are much more important for long-term health rather than looking at weights. So I would say look at length, which is a very important mark of nutrition, and give less importance to weight. So length would be much more important. And even in that, you should remember only 10% of children born small for gestation age have significant growth failure. And those are who fail to catch up growth at 2 years of age are the ones who are going to monitor. So I think pediatricians are in a very, very niche or a very niche environment. You are with the family, they love you, they respect you, they listen to what you say. So you can always tell the family, you're going to keep this child on a very close follow-up and follow them up long-term and keep a close watch. Always tell them before the thing, prevention is better than cure. There's no point in asking them, telling the adolescents after they start, you should talk to children before they reach adolescence. They will listen to you. Once they reach adolescence, they think you're a stupid person. And I think Ismail can always, accept what I say. You are a better friend for your son's friend than your own son.
Yes, absolutely.
So keep track for your friends. Keep track of your children's friends. You can get so much more out of them, and they will listen to you and take your point across to that child. Your son is not going to listen to you. He knows his parents are idiots. He knows everything better than both of them do. And they actually only know to yell at them and can't listen to what they say. They are already born with the preconceived idea or stepping into adolescence with a preconceived idea. So the best person into the situation is a friend of your child. So I think that way you monitor these children from being born SGA. Don't push food into the mouth. I see educated, well-educated mothers, if they are at home, I always say, an idle mind is the devil's workshop, and that is perfectly fitting for moms who are educated and who are sitting at home and have nothing more than to do rather than stuffing food into the child's mouth. That is like a dustbin. You don't want to waste anything. As soon as the child opens the mouth, something is stuffed in. And then after some time, they lose the sense of satiety and the sense of appetite. When you start stuffing in food by 10 months of age, the child, that is when they start appreciating what is appetite. And then they also know, okay, I'm full. I've had enough. I don't want any more. And they say, no, just leave them alone. Don't feed them again. Stop feeding children. So I think that is one important point. That is a point where you should have started prevention for PCOS. So stuffing food in, when the child says no, let them go. They can eat one mouthful. I always tell families, a child can eat one mouthful and can run 100 kilometers. I mean, that might look like 100 kilometers to you, but they have enough energy to run, means they have enough energy in them. You don't have to stuff food into them. So children who are force-fed, again, develop obesity. I think these are the points. I'm only trying to touch points because everything else has been done, Ismail. I have nothing left in my slides. Everybody else has talked about my slides. So modifiable risk factors and unmodifiable risk factors. Okay, so unmodifiable, the genetics you are born with. Girls with lipodystrophy can give birth to children with androgen excess exposure in the intrauterine life, and they will be having an increased tendency to develop PCOS. Girls who are born with PCOS, when they become pregnant, then they can have children with risk for PCOS, which is about 5 times more. So we always say, I think that fits perfectly for PCOS. It is the mother's PCOS condition which puts the child also at a risk. Please remember, there are not only obese PCOS, you also have lean PCOS. Without obesity, you can have PCOS. So that is about 10 to 20% of PCOS can be thin, can be fit. I have a basketball player who has PCOS. So you should remember, PCOS does not happen only because of obesity. It can happen due to a number of other factors too. So this is actually a data which I took out of my sister's hospital. We did a short study. So out of the PCOS who had come for treatment in young women, obese were 88%, overweight were 44%, and obese was 44%. Lean PCOS was 12%. And the mean age at menarche was not delayed. It was as normal as all the other patients who had come in. What are the clues we are getting from thin PCOS girls? Elevated testosterone, dehydroepiandrosterone sulfate, androstenedione, LH, insulin resistance. And these are all directly related to the insulin level. So you should remember, even if you're thin, you can develop PCOS. Okay, so this is one of my girl who came at 4 years of age. The mom was deeply worried, looking at the amount of hair she has on the back. Just look at the amount of hair she has. But she doesn't have hair on the face. So this is actually a vellus hypertrichosis, and this is a non-sexual hair, and this is not a sexual hair. And usually you should remember the features of PCOS are much more evident after onset of puberty. So that's the next point I wanted to raise. So your features of PCOS are evident only after onset of puberty, but you will have minor clues even from a young age on these children having a risk for PCOS later, and you should intervene now. So this is well as hypertrichosis. This is usually familial. Ask the parent whether the dad has body hair, the mom has body hair, and these are fine. These are asexual hair, and this has nothing to do with PCOS. Okay, this is premature puberty. You will see any number of children coming into your clinic with premature puberty. A few fine, thin hair in the pubic region, which does not increase too much, does not become too much. You don't see any changes of estrogenization of the vulva. You don't have changes of thelarchy. You don't have anything else but minor, thin pubic hair, and the family is worried. This is premature puberty. This is a very important clue. These children are at risk for PCOS as soon as their puberty starts. And these are children where you should institute modifiable risk factors can be modified. Your diet, your exercise should start now, not when the child has gone into adolescence and has started PCOS-like features. They don't listen to you. I think Dr. Newton mentioned that girls in the adolescent age group only exercise for 10 minutes a day. Boys exercise for 45 minutes. You need at least minimum of 30 to 60 minutes of moderate degree aerobic exercise, like Lakshmi Shanti said, and they're not going to listen to you when they go into puberty. They've already turned into a couch potato. So this age is the time when you intervene to prevent the PCOS. So premature puberty is an important clue for later risk for PCOS. And there is one group in Spain which is working on using drugs like metformin, pioglitazone, and flutamide. I'm not at all for it. You don't know the long-term risks of that. So it is much better to institute lifestyle modifications rather than trying drugs. And this age is the appropriate age to try treatment. Okay, this is an established case. So this is a teenager who's deeply depressed, has got severe acanthosis nigricans, hirsutism, and I think all of you know about your Ferryman-Galway scoring. So which is anything more than 8 is a significant hirsutism. Please remember, hirsutism is much more common in South Indian population. It may not be that much evident in a child of a North Indian origin. You have to remember, people are moving about in the country. So just because they do not have hirsutism does not mean they don't have hyperandrogenism. They can have other clinical features of hyperandrogenism. So the etiology of PCOS, it could be genetic, it could be environmental. So you are born, I always talk about having 2 children in the family. Both of them inherit one set, a haplotype, 23 chromosomes from their mom and 23 chromosomes from their dad. But then when they grow up, you see one child having early puberty and being of an average height. The other child having late puberty and being tall. So where did this come from? The mom is short, and the mom is short and intelligent. The dad is tall but a bit dull. I think Ismail relates to it a bit. But then the child is so worried because he was born short and dull. At least the mother was short and intelligent. The father was tall and dull. But he had the burst of both features. So what does that mean? That is the environmental influence. So you get the same genetic sequence from your parents, but one character is exhibited, whereas the other character is inhibited. So that is methylation. This is dependent on the maternal nutrition. So if the mom's nutrition is not good, everybody was talking about the mother needing iron, the mother needing, there is a study going on in Mysore from I think Holsworth Memorial Hospital with the team from UK. They are trying to institute B12 and B complex vitamins in the mother to see if it would improve the health of the offspring, the metabolic health of the offspring. So Holsworth Memorial Hospital is on a huge study. It's actually a community-based study. So the maternal health is extremely important. So you're going to start prevention of PCOS from looking at the health of the mother, the health during pregnancy, because to prevent SGA, then during birth, and then the immediate infantile period, prevention of catch-up growth, and then avoiding risk factors that can happen because of precocious puberty, and then all of these steps will prevent PCOS in the adolescents. Adolescents, it's almost the final step and the PCOS has started. That's a little bit late in the initiation of treatment, because Ismail was very specific that I don't talk too much about exotic drugs. And as such, also treatment of PCOS is 95% lifestyle modification, and medication is less than 5%. No, I won't even say 5. I would say less than 2% is the treatment based on medication. Lifestyle modification is the backbone of therapy for polycystic ovarian syndrome. So, in utero androgen excess programs later PCOS at adulthood. So there are two hypotheses: prenatal androgen hypothesis and adipose expandability hypothesis. I think again I will come back to Dr. Newton's Barker's hypothesis. So you have smaller fat cells. Please remember, for all of your information, fat is also an endocrine organ. It has so many hormones. It's got adipokine, it's got leptin, it's got bisfatin, and so many other hormones are being produced by a fat cell. A fat cell is an endocrine organ, and there are so many hormones coming out of it. So the fat actually is altered by the intrauterine environment so that it is unable, whenever you have extra fat, I always talk about in Tamil, பஞ்சத்துல அடிப்பட்டவனுக்கு நிறைய சாப்பாடு கொடுத்தா இல்ல நிறைய அரிசி மூட்டை கொடுத்தீங்கன்னா they won't cook everything immediately. They will store it for future when they cannot have enough food. So that is how your epigenetic malformations happen, modification happen. ஒரு குழந்தை ஒரு அம்மாவுக்கு பிறக்கும் போது சின்ன வெயிட்டா பிறந்தா உள்ளுக்குள்ளார பிளசண்டா சரியா வளரல, அப்ப அந்த குழந்தை பஞ்சத்துல அடிபட்டு போச்சு. ஸோ அந்த குழந்தையோட கொழுப்பு மாறிடும், அதோட உருவத்தை மாத்திடும், அதோட வேலையை மாத்திடும். அப்போ கொஞ்சம் சாப்பாடு கொடுத்தாலே நிறைய கொழுப்பா ஸ்டோர் பண்ணும். You need only little food to become fat earlier in small for gestation age infants. That is the backbone of the Barker's hypothesis. You have been conditioned by the environment you were exposed in the intrauterine life. பஞ்சத்துல அடிபட்டதுனால நிறைய சாப்பாடு கிடைக்கும் போது you will store it as fat. Please remember there is transgenerational. That is, the child of this child can also be affected by the same. It is going to take at least 2 generations of good, healthy nutrition to get a good society with a healthy metabolism. So, இந்த குழந்தை பஞ்சத்துல அடிபட்டா அதோட குழந்தைக்கும் அதே எஃபெக்ட் வரும். Because that has been proved by one study in preterms by Dr. Sarah Mathai from CMC Bangalore. She has actually worked on preterms and the transgenerational transformation of information across across generations for the metabolic defects. So you have to remember, in the சமுதாயத்துல இந்த ஜெனரேஷன் மட்டும் இல்ல, இதுக்கு அடுத்த ஜெனரேஷனும் நல்லா இருந்தாக்கா Indian society is going to be healthy. Till then, the Indian subcontinent, particularly the South Indian subcontinent, is at a higher risk for metabolic diseases and at smaller weight gains. You don't have to be huge. Even small weight gains will put you at a higher risk for diseases in later life. So critical periods in fetal life, periods of rapid, I think Dr. Newton has already alluded to all this earlier. So changes in gene expression without alteration in DNA sequence. Get the same gene, but the way your genes are expressed are dependent on the environment you are exposed to, both intrauterine and extrauterine. So SGA or prematurity versus PCOS. So they have increased incidence of precocious puberty. They have an increased incidence for risk of, and they have an increased risk for overweight and obesity. This overweight and obesity makes them at a risk for PCOS. They have pronounced puberty, and they have, remember, androgens are produced from 2 sources. One is the ovary, the other is the adrenal gland. The adrenal gland is under the control of the ACTH. The ovary is under the control of the LH. So when you have PCOS, you have high LH. This leads to functional ovarian hyperandrogenism. So 17 OHP adrenal mattum illa ovary li irukku. And the 17 OHP becomes more active in children who have all these risk factors and start producing more androgens from the ovary. So this is another child with precocious or premature puberty. So this is associated with hyperinsulinism, and this can lead, and this worsens it. The ovarian hyperandrogenism is worsened by this, and this is a very vicious cycle that can happen. So PCOS in women born SGA is twice the incidence of those born appropriate for gestational age. They have hyperandrogenism, where sex hormone binding globulin is low. Again, your muscle mass comes into action here, as Dr. Newton was mentioning about the muscle mass in SGA. Sex hormone binding globulin is lower in these girls. So modifiable risk factor or SGA with catch-up weight. Your born SGA, that's unmodifiable, but you can modify the catch-up weight. diet and exercise, and seeing that the mothers who give birth to these children are healthy. What are the unmodifiable risk factors? A family member with PCOS, the risk for PCOS in the child is 5 times more. Androgen excess conditions in the mother, SGA, large for gestational age infants, and then lipodystrophy, genetic insulin resistance syndromes, and others. These அந்த சொத்தை ஒன்றும் செய்ய முடியாது. At least இனிமே சேர்க்கிற சொத்தையாவது நல்ல சொத்தா சேர்த்துக்கலாம். So this is a case scenario: a 15-year-old girl born SGA, birth weight 1.9 kilograms. See, you also have to remember SGA does not fit into one just cutoff mark. Like we all studied in Meherban Singh, less than 2.5 kg is SGA, more than 2.5 kg is AGA. It's not like that. It is just a range of weights. So across the weight, as you grow lower and lower, your risk factors become more and more. As you grow higher and higher, 3 kgs is actually an appropriate weight. Anything more than 2.7 to 2.8, they have better outcomes. Even less than 2.8, we see risk factors for similar to other SGAs, but it is worse in even smaller babies. She's worried about dark, thick facial hair, depressed and refused to attend school, and mother has similar facial hair but less severe. And this is the girl which we talked about. So she's obese, her waist-hip ratio. Remember again the adipose expandability tissue. வயத்துல இருக்கிற தொப்பை தான் இருக்கிறதுல உலகத்திலே மோசமான கொழுப்பு. மனசுல இருக்கிற கொழுப்பை விட தொப்பையில இருக்கிற கொழுப்பு தான் வேர்ஸான கொழுப்பு. Because that is almost proportional to the visceral fat that you have, which is in the liver. The visceral fat is the metabolically active fat and actually alters and worsens your metabolism in later life. So your visceral fat is almost proportional. That is why if you look at all Indian males who get married, within the 2 months, the first property they acquire is the toppe. The abdominal fat is the first, what do you say, the gain you get from the marriage, even more than the happiness from anything else. After all the parties and all the food festivals, all your family members invited you to, that will come and all your metabolism will go haywire. It is not the wife who spoiled you, it is the food that spoiled you. So you can't blame your wife for everything in your life. That's for you, Ismail. Severe hirsutism, Ferryman-Galway scoring. Acne is again a sign of hyperandrogenism. Skin tags. You see small black skin tags. That is also actually a sign of hyperandrogenism. That is not something that is just structural or something that a dermatologist worries about. It's a sign of hyperandrogenism. Severe acanthosis. But remember, acanthosis is not proportional to the amount of insulin resistance you have. So this is your Ferryman-Galway score. It is available on the internet. It's a score of 1, 2, 3, and 4, depending on the intensity. It is scored on 9 different areas. The maximum score is 36. Anything more than 8 is severe hirsutism. It's hirsutism. So diagnostic criteria for PCOS, you should have at least 2. Clinical or biochemical signs of hyperandrogenism, oligoranovulation, and polycystic ovaries. All of these are not important in children if you suspect, but please remember, be very, very careful about labeling somebody PCOS. You should wait at least for 2 years post-puberty before you can even think of labeling them as PCOS. Unless they have excessive clinical features of PCOS, please be very, very careful of labeling somebody as a PCOS. But you should exclude other etiologies like congenital adrenal hyperplasia, androgen secreting tumors, or Cushing syndrome. So in children, adolescents, they say all 3 features. It is not important to have only clinical features. You have to document hyperandrogens in the blood. You should have oligomenorrhea or amenorrhea at least for 2 years post-menarche, because as such, girls have irregular periods for the first 2 years post-puberty. And then, or primary amenorrhea at age 16 years, and the ovarian volume is important. It should be more than 10 centimeters cube to diagnose polycystic ovaries in girls. And you should remember that mala mari or appearance, whereas the cysts in hypothyroidism will be huge, water-filled, clefted cysts, whereas the cyst will be arranged like a rosette in a child with polycystic ovarian disease. So I think the investigations will come later, clinical judgment itself, and you can institute steps. Only when they have significant morbidity because of that, you should intervene with drugs. So this is one of my girl. I think this is the same girl who was in the front. So she's a polycystic ovarian disease. This is another girl, same age group. She also came. She had delayed puberty, 14 years, has not had any changes. So she actually was a non-classic congenital adrenal hyperplasia who had been missed till 14 years of age. It's very difficult to differentiate between severe PCOS and non-classic congenital adrenal hyperplasia. And this is a place for investigation where you have to rule out what the reason is. Third, This is a very, very famous model called Harman Kaur in the UK. She models with her beard. So I think in this adolescence where you were all talking about body image, I think you have to teach them to learn acceptance. This girl had actually tried to she attempted suicide about a few years ago. Then she learned to accept that her body is there. She stopped shaving. She stopped responding to bullies, and now she goes around with a beard. She's a lean PCOS with a beard and models like that. And she's actually a motivational speaker in the UK. So virilizing CAH versus polycystic ovarian disease, a bit difficult to judge without doing investigations. Treatment is individualized. It cannot be be all, or it cannot be one size cannot fit everyone. Lifestyle modification is the cornerstone of therapy. For hirsutism, please don't do shaving, depilation, or waxing before reducing the androgen excess in the blood. Only after you achieve reduction in androgen excess, you can initiate the final treatment for hirsutism with local measures. If you keep doing laser, it's about 40,000, 50,000 rupees for a few sessions of laser therapy, depending on where you go. It may be even more expensive, and finally you don't achieve anything because you've not. Noi nadi, noi modal nadi, adu nadi vaipa chel. Thirukural. You have to look after the basic disease first before you try treatment modalities. So the androgen excess has to be brought down before you initiate local steps. Metformin, there are also talks about pioglitazones and GLP-1 agonists. Liraglutide has been approved for therapy in adolescents also with obesity. But I think we have to wait to try. I always wait for 10 years to see where the side effects are going before I try anything in children. Oral contraceptive pills, the pros and cons of a low dose versus high dose ethinyl estradiol, anti-androgens, spironolactone, finasteride, and flutamide. I'm very, very comfortable with spironolactone. I'm a bit worried about finasteride and flutamide, and hepatic side effects are something which really worries me. So this is one of my girls and a heroine. So she actually came with, look at the amount of beard she has. She was so depressed. And please see, this is the same girl. I've not changed the girl. It's the same. And she's also wearing the same earring to satisfy me, I think. So she actually went through lifestyle modification, dropped. You don't have to drop too much. I'll come to that slide later. She dropped a bit of her weight, and then we instituted measures to reduce her androgens. We did not even go to laser therapy. All her hair started dropping on its own. It takes time. It takes at least minimum of 1.5 to 2 years to achieve a reasonable outcome. So diet and exercise in PCOS, differences in dietary intake and physical activity alone cannot explain difference in weight between women with and without PCOS. கொஞ்சம் கன்ஃபியூசிங்கா இருக்கு. ஸோ சாப்பிட்றதுனாலே எக்ஸசைஸ் பண்ணாதனாலே பிசிஎஸ் வராமல் இருக்க போகிறது கிடையாது. பட் அது பெட்டராக உங்களை இம்ப்ரூவ் பண்ணக்கு உதவும். ஸோ 2 to 5% weight loss போகும் to improve several parameters that are associated with PCOS, which includes insulin sensitivity, your heart disease risk, homocysteine, androgens, abdominal fat, menstrual regularity, lipid profile, fertility, just 2 to 5% weight loss, which is achievable. So, இழிவருந்து உண்பான் கண் இன்பம் போல் நிற்கும் கழிப்பேர் இறையான் கண் நோய். Pleasure dwells within those who eat moderately. Disease dwells within those who eat gluttonly. So this is our ancient Turukural, which is more than 2,500 years old. So lifestyle modification, I think it's already been talked about enough. So diet, exercise, and behavior therapy. Exercise more than, I think, a minimum of 60 minutes daily, and it should be moderate intensity. Reduce saturated and trans fat and glycemic load. So 30%, like Lakshmi Shanti said, 30% fat, 15% protein, 55% carbs, and saturated fat should be less than 10%. High in cereal fiber and polyunsaturated fat. No smoking or alcohol. Again, heads. Heads has to be done when the child enters adolescence, not when they're going through adolescence. So that is a mandatory requirement in our diabetes clinic abroad. At 10 years of age, we start our counseling for adolescents. By 10 to 12 years, it's the time when we are transitioning them into the adolescent clinic. We would already have started all our counseling, seen that our counseling is done. We have taken heads. We have also done enough to see that they don't go into that bad behavior as much as possible. We've tried our best before they enter adolescence. So I think the time for intervention is 10 to 12 years and not after you enter adolescence. Reduce stress and family support. Weight loss through lifestyle modification, as I already said. Avoid crash diets, and I think all of them have mentioned it again. Short-term weight loss. Aggressive surgical approach is not necessary. Please be very, very careful about the advocation of bariatric surgery. It has important and excellent criteria that has to be fulfilled before you suggest bariatric surgery for somebody. It is suggested for people with specific body mass index of so much and so much percentage more than that, plus 2 severe associated comorbidities, and when their lifespan is going to be compromised. Otherwise, bariatric surgery is not for adolescents. But it has a role to play in really severe situations. So, but it is not an aggressive surgical approach for everyone. Sensible, sustainable diet pattern, and I already mentioned 30% fat where less than 10% is saturated, 15% protein, and 55% carbs. So this is another of my girls. She's a congenital, non-classical, late onset CAH. Look at how depressed. Just look at her lips. She's got such a sad look, a frontal baldness, recessive frontal baldness. And then the same girl, after adequate and successful treatment, she's now finished college and she's doing extremely well. So it is possible to achieve the best for your children. And I think the pediatricians can watch for children born from high-risk scenario. And any early feature suggesting a risk can evoke advice for early lifestyle intervention. Prevention is better than cure, and empathetic advice of pediatricians helps family to institute early remedial measures. Thanks.
Thank you, Aguila. இந்த மாதிரி நல்ல ஒரு புரியும்படி கருத்துக்களை சொல்றது தான் எங்களுக்கு ஒன்றை ஹெவியா லைக் பண்ண வைக்குது. Of course, we are looking forward for a endocrinology series for the pediatricians. IAP will try and approach you for that, and we will soon contact you on that aspect. And very reasonably and very clearly dealt with the subject. And I think pediatrician will really have some take-home messages. And I think they will be very clear about what is PCOS mean.
உண்மையா சொல்லிடுங்க. உண்மையா புரியுதா?
மனசை தொட்டு சொல்றேன். ரூம் போட்டு யோசிச்சு சொல்லல. Very good, very good. I think, I don't know what Usha is going to do with that. After that, you have done everything. Is Usha there?
Yeah, I'm there. So having listened to the whole scenario, the whole thing in the afternoon, I think everybody did an excellent job. And Agila's was a muttaipu, and I think I'm like an Anumar wall, but still you need the wall sometime. So
Yes.
I think,
1 minute, I'll introduce you, Usha.
Yeah, please.
Of course, Dr. Usha is a practicing pediatrician in Coimbatore. She is very much interested in adolescent, and she is going to be the president of the Adolescent Health Academy, which is going to be instituted very soon, the Coimbatore chapter. And she is very well versed and a very person who has got immense experience in dealing with an adolescent. With these few words, I invite Usha for a message.
Do the finale.
Yeah.
Well, I think everything was dealt with a lot of clarity and with a lot of professionalism. So I think very little is there. I think the highlight of the whole afternoon was this exercise bit, the lifestyle modification and recognition of PCOS and the approach to it and all that. So I think the exercise bit, the lifestyle modification, not only for PCOS, but even for any adolescent for that matter, should be introduced much earlier in life. Even this should be part and parcel of the school curriculum, which I'm always working on whenever we go to schools to do the adolescent program. And in the lifestyle modification, the highlight of the thought I had was setting the right goals is the most important step. Having very effective goals, the goals being very realistic and attainable goals, especially for these adolescent PCOS, to lose weight and to have a good lose the facial hirsutism and be very presentable. For example, this is one type of job which is easily said than done. Having all of us gone through these weight loss goals throughout our lives, it's very easily said, but exercise more is a fine goal, but it is not very specific for an adolescent. We can easily tell them, walk 5 miles or do 30 minutes every day. But is it attainable? Is it measurable? Or is it achievable? That's what we have to think. So this 30 minutes to 40 minutes per day, sometimes I come across adolescents who have just not motivated enough to do even the 30 minutes. So it could be 10 minutes split through the day for that 40 minutes. As long as they don't have the sitting syndrome, we should just motivate them to do that 30 to 40 minutes PCOS or not PCOS too. So at least we could give them a goal of walking 30 to 40 minutes, 5 days a week, which is very specific, achievable, and is quite forgiving. And according to the diet, I had a question for Akhila, because I'm also I was also propagating keto diet for some of the adolescents who have morbid obesity, and running a sports center, we do give them some kind of programs to lose weight. So the carbohydrate being 30% and little higher fat and protein 15%, it did help a lot of adolescents I came across to lose weight. Do you advocate that? That's a question to Aguila. I personally experienced for some adolescents with very good results. Now, regarding diet, I think most Lakshmi Shanti, Dr. Newton all had covered it very well. A sensible diet and a changing eating habits is very long term. The percentage of calories has already been discussed, like 1,000 to 1,200. Weight loss program has been discussed, cutting down on the salt intake, reducing. So all that has already been stressed upon. Only thing I needed to add was this kind of a ketogenic diet. Does it help these children? And exercise start as early as possible, and let's introduce in schools. Let's try to contact people to take the message to school saying that this has to be started as early as possible in schools, starting from first standard onwards. That is this thing, so that it becomes part and parcel of life. I think most of it has been discussed.
Yeah, I'll answer that question, Usha. For ketogenic diet, it has too much of fat. We don't know the long-term effects of what we are giving. Any change in your vasculature, see in insulin resistance, it is the increase in nitrous oxide and reduction in the pulsatility of your vasculature, which actually leads to the deposition of cholesterol on your vessel walls. That is the start. So you should actually remember diabetes and hypertension, rendu per annan thambi. They are coming from the same parents. They are only actually a difference in the way they have been born. So it's actually the basic pathology is the same. Both diabetes and hypertension have the same pathology. It's the non-pulsatility of the vasculature which leads to the deposition of cholesterol on that. So in children who are already obese and they have insulin resistance, trying to put in so much of fat, I mean, there's no long-term data on how is it going to affect them in the long run. So I would actually say, இயற்கைக்கு மாறா எதுவும் செய்ய வேண்டாம். I always tell families, உங்க கொள்ளு பாட்டி கொள்ளு தாத்தா என்ன சாப்பிட்டாங்கன்னா சாப்பிடுங்க. In those days for Deepavali and Pongal, we had தீபாவளிக்கு ஒரே ஒரு அதிரசம் தான் எங்க பாட்டி தருவாங்க. அதுவும் பேத்திக்குன்னா சின்னதா கிடைக்கும், பேரனுக்குன்னா கொஞ்சம் பெருசா கிடைக்கும். ஸோ ஒரு அதிரசம் தீபாவளிக்கு. பொங்கலுக்கு சக்கரை பொங்கல், நெய்யெல்லாம் ஊற்ற மாட்டாங்க கிராமத்துல. 4 அப்புதான் அப்போ அவங்க கேட்டாக்க. அப்புறம் கோயில் திருவிழாக்கு மாவிளக்கு கிடைக்கும். 3 தான் ஸ்வீட் வருஷத்துக்கு. So that's all you can have. You can't have sweets every day just because Araya Ananda Bhavan managed to open one branch in every street in your space. So the lifestyle your grandparents followed is, and they never had a vehicle to go. So மாட்டு வண்டியில மூட்டையை தான் ஏத்துவாங்க. மாடுக்கு வலிக்குன்னு ஆள் ஏற மாட்டாங்க மாட்டு வண்டியில, பக்கத்துல நடந்து தான் போவாங்க. So 22 கிலோமீட்டர் நடந்து போய் தான் நெல் விக்கணும். So you walk 22 kilometers and you had so much of rice. Now you sit and eat so much of rice than that. So it's actually the balance. I would say I wouldn't go for any food fat. I would just say a regular sensible diet with high fiber. And anyway, in those days, kai kutal orala da idigina arisi. Adella polish varavallikella adigum mudiyadhu. Konjam kurniyoda da konjam mela apdiye umiyoda da varum. Adha sethu da vendu da saappanum. So that was a very, very good diet. So I would say a sensible diet which everybody followed for years together. That would be actually much better. Only thing, அளவுக்கு மீறினால் அமிர்தமும் நஞ்சு, which holds good for any food. I would say I wouldn't go for high fat diet at all because I don't know the long term effects, and the data is still pending. It's only short term data which have come out. There is no long term data on that.
Okay, Dr. Akila, one more question from Dr. Arunachalam from Nagarkoil. What will happen to the, I don't know what does it mean, what will happen to the endocrine system? Dr. Arunachalam, you're there?
Endocrine system, நான் தான் சொல்லிட்டேனே, கொழுப்பே endocrine system சொல்லிட்டேன். கொழுப்பு கூடி போய்டும்.
Answer, you are very obvious in your answers. Very good. So any other, you want to add something?
டைரக்டாவே ஒரு கேக் சொல்லுங்க, நம்ம நேருக்கு நேர் போய்.
Dr. Arunachalam.
I have one more question, Aguila. Do you have any other drugs indicated for his, apart from metformin, like I remember I've seen some prescriptions, some of them using rosiglitazone, some of them still using those drugs.
No, okay. So glitazones are very good for reducing insulin resistance. But remember, there is one unknown side effect which not many people or any article mention. It affects the function of the osteoblasts. In the long run, you will lose your bone mineral density, and puberty is the period where you go through maximum bone mass accrual in your life. Your lifetime bone mass accrual, the maximum happens during puberty. And if you're going to interfere with the accrual by using drugs, your long-term bone health is going to be affected. So you can't sacrifice for that sake. What I use, metformin also will not work for hirsutism. For hirsutism, what we do is after diet and exercise, you have to use anti-androgens, where spironolactone is an excellent drug. The next one I use is cyproterone acetate. And these are, I've only had to use these two and I've had excellent results. So I haven't gone beyond that so far.
Okay, thank you, Aguila. In the kadaya moodnada na bappo ellaru and the kadaya thorakku mudiyum.
Okay, Dr.
Yes, please.
Dr. Preeti is there. Your final comments, Dr. Preeti. Unmute yourself.
I think it was an excellent CME, and I hope to see many more AHA chapters in Tamil Nadu. So all the best to everybody, and congratulations to Dr. Usha and Coimbatore branch. So advance congratulations. Looking forward to the launch of Coimbatore AHA.
Thank you, Dr. Preeti.
Dr. Lakshmi Shanti is the secretary, ma'am.
Yes, I know. It's a congratulations.
I contacted her, sir.
Yeah, Dr. Newton, your final comments. Unmute. Okay, then we'll wind up. I would like to say wind up like saying that Dr. Mona Bhaskar had told that, and Dr. Sripriya was telling about the body image issues and how about the so that body image is concerns the body is for them. It is their only I mean their what to say முதலீடு in Tamil நம்ம சொல்லும்போது. So Dr. Mona said celebrate all sizes. That was the message. And Dr. Swati madam told that role modeling of the parents. That was the message. And Dr. Preeti, mindfulness. And yes, she wanted to rule out organic diseases before saying it is as a mental health issues there. So next was Dr. Lakshmi Shanti and Dr. Newton. They emphasized on sleep, exercise, and 24. Newton said, 24 hours you want to be dead, 1 hour exercise is enough. So 23 hours, what happens? So that was a good question. And so in PCOS, Akhila said, Arthanarishwarar, lean PCOS, fat is an endocrine organ, and you must be careful about this SGA babies and SGA those were and catch them young. So that was her and Dr. Usha. Sports has to be included in the curriculum. IAP has to take this.
To the schools.
I think you have to take a very, very, very strong
first standard.
Yeah, you have to take it. CIAP and our body has to take it. So that was very, very setting right and
right
effective goals. So that is a wonderful message. So this is what happened today. So wonderful. Dr. Rajendran, please.
Yeah, thank you, sir. I think you made my job easy to a concluding remark. I think I will change to vote of thanks, and I thank Dr. Major Nagaraju and Vice President South Zone. Thank Dr. Nagaraj sir. I thank Dr. Muhammad Ismail sir for giving this opportunity to use IAP platform to conduct that pediatric that's adolescent CME. And I thank Dr. Gopal Subramaniam, Treasurer, IAP TNSC. And I thank Dr. Sripriya, Dr. Aram Sendil sir, he is an instrument of this CME. And Dr. Vijarani is Madam is also a coordinator for this program. I thank my colleague Dr. Lakshmi Shanti, our Coimbaturian Dr. Agila Ayavu, Dr. Usha Elangovan, and I thank our all India experts like Mona Bhaskar, Swati Bave, and Dr. Preeti and Dr. Newton Lewis for this wonderful opportunity. And this, we are happy to announce that we are going to have, as sir said, now Coimbatore, we are having opening two adolescent topic. One is from Coimbatore, another one is from Kadalur. Kadalur, they are also going to open the adolescent chapter, and under effort of Dr. Aram Sendil sir. And I thank one and all for this wonderful event. And I finally thank our important person, Dr. Thirumurugan Sarani. He is an important person to make a flyer and organize this event. I thank Dr. Thirumurugan, and I thank one and all for this event. Thank you. Thank you.
Yeah, before we close, I think I should thank Dr. Aram Sendil and Dr. Vijayarani for coordinating and planning and implementing and conducting in a very nice way. And really, it went on very well. Thank you, Sendil and Dr. Vijayarani. And I extremely thank all the national faculties and the speakers who made it is really vibrating event. Actually, it went on very well. And of course, I think Dr. Rajendran, who has started in a very shrewd way right from day one. I think he has been very instrumental contacting people, arranging all the aspects. I think I really appreciate our secretary, Dr. Rajendran, for doing wonderful things. Thank you, one and all. We'll meet again in the next CME 31st.
Thank you, one and all. Thanks to all the faculty, speakers, all those who are listening, all the delegates. Thank you. Thank you, Dr.
Bye. Thank you. Bye.
Thank you, Dr. Preeti, Dr. Akila. My favorite speaker today.
What எனக்கு தான்
நீ திருக்குறள் சொன்னா அவளுக்கு பிடிக்கும்.
நான் என்னோட PhD தீசிஸ்ல திருக்குறள் தான் ஃபர்ஸ்ட்ல எழுதி இருக்கேன்.
சூப்பர்.
மகன் தந்தை காற்றும் உதவி இவன் மகன் என்னோற்றான் கொல் எனும் சொல். அதுதான் போட்டோல எங்க ப்ரொஃபசர் சொன்னாரு, என்னன்னாவது எழுது, யாராவது நீ கர்ஸ் பண்றேன்னு நினைச்சுக்க போறாங்கன்னு சொன்னாரு.
ஸ்ரீபிரியா ஆரம்பிச்சது எல்லாம் இப்படி அழகா போய் அழகா உஷா வந்து முடிச்சிட்டாங்க.
நல்லா இருந்தது ஆக்சுவலா.
டாக்டர் திருமுருகன், தேங்க்யூ. வணக்கம்.
தேங்க்யூ திருமுருகன்.
அனைவருக்கும் நன்றி.
Thank you, sir. Thank you, sir. Thank you.
Thank you, டாக்டர். சாரி டாக்டர், ரொம்ப படுத்திட்டோம். Thank you.
ஆமா. தலையில போட்டுறோம் நாங்க.
பரவாயில்ல சார், அதெல்லாம் ஒண்ணும் இல்ல சார். நம்ம ஐஏபிக்காக தானே சார் பண்றோம்.
இப்படி ஏமாத்தலாம் சிக்கிறாதீங்க, வச்சு செஞ்சிடுவாங்க.
மேடம் ஏற்கனவே வச்சு செஞ்சிட்டாங்க. அதெல்லாம் இல்ல. ஓடிட்டு இருக்கு அப்படியே.
ஏதோ செஞ்சிட்டு இருக்காரு.
அகிலா, நீ இன்னும் போகலையா?
நான் கவனிச்சிட்டு இருக்கேன், ஒட்டு கேட்டுக்கிட்டு இருக்கேன்.
நீ முதல்ல இடத்த காலி பண்ணுதா, எங்களுக்கு 1 வருஷம் ஓடணும்.